All right, good morning, good afternoon, everybody. I'm Amy Ronshausen, and I'm the Executive Director of the Drug Free America Foundation and the International President of the World Federation Against Drugs. On behalf of both organizations, I'd like to welcome you to our half-day summit on reframing global prevention practices and policies during COVID-19. I know you have many virtual invitations, so I want to thank you for taking the time to join us today to hear from the great lineup of speakers we have. My co-host today is a leader in the prevention field, an inspiring colleague, and a dear friend of mine, Mr. Carlton Hall. You will hear from him later as he moderates our first panel. And behind the scenes, and you've heard from him already this morning, making all of this work happen is the amazing Dave Clausen, the director of the Mid-America PTTC, the Prevention Technical Training Center Network. So before we get started, I'll go through a few housekeeping items. I'm sure you are all pros at this by now, but please remember to keep yourself muted during the presentations to minimize any kind of distractions. You should have all received an agenda in your event reminder email, but here's a quick rundown. We'll start with an opening keynote followed by a 10-minute break. After the break, we will have our first panel presentations with 3 panelists and then a question and answer session at the end. We will have another break before we'll start our second panel, which will follow the same format as the first. And then the event will end with a closing keynote. Please use the chat section that you guys have already started using to communicate with us and with each other during the event. We encourage conversation. You can also use the chat section or the question and answer section for any questions that you have that you want to ask to the speakers. Both Carlton and I will keep an eye out for your questions and make sure that they are asked at the appropriate time to the appropriate people. The event is being recorded and we will send that out to you in an email in case you missed part of it, or if you want to watch it again, or you want to share it with your colleagues. So I think we can all relate that 2020 has been a year like any other, and we're glad to see that it's over. We have been challenged personally and professionally in 2020. Our mental health, physical health, and spiritual wellness has been pushed to the limits and then some. But what all of us here today have in common is from the very start of this, we understood that the COVID pandemic was going to have major impacts on the global drug crisis. Previous research demonstrates that prevention use as well as deaths related to drug and alcohol use increased during times of social and economic upheaval. Measures put in place to combat the COVID-19 pandemic, such as shelter-in-place orders, have been associated with negative emotions such as irritability, anxiety, fear, sadness, anger, or boredom. These conditions often initiate drug use, trigger relapse, even in those in long-term recovery, or intensify drug consumption. In addition to being a catalyst for drug use, COVID-19 has caused limited medical assistance for substance use disorders because most medical efforts are geared toward the pandemic. Shelter-in-place orders have pushed everyone into isolation, leading to a decreased access to prevention and treatment services, as well as a decreased access to healthy outlets and activities that provide a distraction from addiction. Individuals on medicated assisted treatment had difficulty getting their medication in many parts of the world, which increased their risk for relapse and overdose. While the pandemic has thrust us into uncharted waters, prevention professionals all over the globe are meeting the challenge. Today, we will hear from global prevention experts on how they have adapted their strategies to meet people where they are at, and how advocating for policies that put public health and safety first and a commitment to research remains a priority. It is my pleasure and honor to introduce our opening keynote, Ms. Giovanna Campello. Ms. Campello has more than 20 years of experience with the United Nations Office on Drugs and Crime in supporting member states and national stakeholders at all levels in improving their drug prevention response, applying and contributing to scientific research. Evidence. Most notably in this context, she has led the publication of the International Standards of Drug Use Prevention in 2013 and the UNODC WHO second updated edition in 2018. Since 2016, she has been leading the Prevention, Treatment, and Rehabilitation section of the United Nations Office on Drugs and Crime, thus promoting evidence-based, gender and human rights sensitive practice on drug prevention, treatment, care, and rehabilitation, as well as access to controlled drug and medical purposes. It is truly an honor to welcome you, Giovanna. Thank you for taking the time to be here with us today.
Hello, dear friends. Can you hear me?
We can.
Yes. Hi. And well, thank you, Amy, for your kind introduction. And actually, the honor and the pleasure is all mine. And I was going to start my presentation by, in fact, thanking you, Carlton and Dave, and your respective organizations for pulling this together. Because what I'm going to present to you is our attempt to address this unprecedented situation in which we have all found ourselves, but it's just one attempt. And in fact, what I'm really looking forward is to learn from all of amazing presentations and the public here on how to improve and expand our response. But still, we have tried to do something. And so I wanted, it's my great opportunity to present it to you. Let me try to challenge my technological ability by sharing my screen and my presentation with you. You should be seeing my presentation if somebody could confirm, because I've lost the rest of the screen, so I don't see what you are seeing.
Yes, we can see it.
Perfect. Thank you so very much. And yeah, so as I was mentioning to you, I wanted to give you an idea what we were doing before COVID, because I think that is, in fact, it is what was informing our work and what has kept informing our work in many, many ways, right? And Amy had already mentioned that in my introduction, how I am behind the development of the international standards on drug use prevention. And I just wanted to give you an idea of how this was informing our practice and why we developed the standards. So the standards, maybe standards is not even the right word, but what the standards are a summary of what works and what does not work in prevention of drug use and other risky behaviors according to science. And you have in front of you the cover of the second updated edition, which we have published in 2018 together with the WHO. But there was a first edition that we published already in 2013 alone. And the reason why we had published that was that I was getting really, really concerned about the fact that I knew that there was a lot of very solid science of what works on prevention and how prevention can be so effective in changing for the better the life and the world of children, youth, and communities, and how there was this huge disconnect with what was going on in practice. And what worse was that this had led to a feeling that I was facing every day when I was talking to delegates from the countries of the United Nations who were coming up to me and saying things like, yeah, Giovanna, very interesting, right? But prevention doesn't really work, does it? And I was saying, yes, it does. I know it does. I've seen the studies. And so the standards were our attempt at pulling that science together to put it at the disposal of everybody. And when I say that I was looking for interventions that really, really work in preventing drug use, this is the kind of studies that I was looking for. And I always present this because it really brings to the attention of people that with prevention, you can really change the life of children. This study is an example of the studies that we used in the standards. And it's a study about a program that is delivered to children that are very, very young. We are talking about 2 to 5 years of age. Yes, kindergarten age. And this is a program that is delivered in marginalized communities and really provides special support to the children and to their families. And in these studies, they have followed some children that went through the program until they went 21 years of age, and you can see them represented in blue. And but they also follow some children that did not go through the program, and they follow them also until they were 21 years of age, and you can see them in red. And you can really see how the kids that went through the program, even when they were so young, at 21, they used significantly less marijuana in the past month. So not occasionally, use more marijuana in the past month was much lower. Teenage pregnancies was much lower, and enrollment in college was much higher. So when I say that we have the evidence that the interventions that are mentioned in the standards really take care of the health and the development of children and youth, that is what I'm talking about. And when I say that really as a result of these interventions, less people use drugs and less people engage in risky behaviors, this is what I'm talking about. And so we did a lot of the development of the standards was a bit long-winded, and normally I explain a little bit of how we did it. But the important thing is that is more about what it led us to do. And so what we found out was that we really needed to change our perspective on prevention, and from away from this very intuitive and basic and important, but too simple understanding that people use drugs because they do not know about the fact that drugs are dangerous. And therefore, prevention is about providing information. Now, as I was saying, this is incredibly important and should not be lost. I'm sure you are all familiar with this graph that comes from the Monitoring the Future kind of data, and that really shows that as the perception of harm of a substance, in this case marijuana, goes up, use goes down, and vice versa. So of course, as in everything, there is a bit a simple understanding of a phenomenon. There is a lot of truth and it should not be lost, but there is also a more complex reality there. This is also a graph that takes data from Monitoring the Future and shows that it's not only information that matters, but parents matter a lot. And in this graph, you can see how the more parental monitoring, the lower is the probability that children use inhalants in this particular case, but there is another graph that is exactly the same also for cannabis. We also know that being in schools or not matters a lot. This graph shows that for kids of 12th grade age, being in school makes an enormous difference in terms of people using psychoactive substances, any kind of psychoactive substances. Children of that age would use more if they're not in school. And we also know that the vulnerability factors interact with each other very much. We know that adverse child experiences such as poverty, violence, and abuse are associated during childhood. They are associated with more substance use later in life. But we also know that it makes a lot of difference if you are from a marginalized or a community or not, because people with higher income and adverse child experiences, 4% were found to be associated with substance use disorder later in life, but that was 3 times higher, 12%, for people from lower income. And in this, and in this graph, this study is from a long study, but it's only limited to the UK. But this study is shows a very similar result, and it looks at data from 50,000 students in 28 European countries. So it's very a strong indication of how inequality interacts with other vulnerability factors. So really, this first part of the arrow of how people, why people use, start to use, is much more complex than we sometimes think about. And it's more something like this. So a long list of vulnerability factors at a personal level, but also in the environment, in the family, in the school, in the peers, and then in the wider environment of the community. And this is a more pretty version that has been produced by the the colleagues that work on the World Drug Report, that shows the balance between vulnerability and resilience factor in the life of people that lead them to start to use substances and develop disorders. And of course, we also knew from the standards and from the science that these vulnerability are common to many risky behaviors. Many of you will know this graph because it's very, very old. It's from 1992. It's from the of the work of Professor Hawkins and Catalano in the United States, but it's still one of the best representations that I have found, that looks at risk factors at the individual level, in the school, in the family, in the community, and shows how they are common to many risky behaviors: substance use, delinquency, teen pregnancy, school dropouts, violence, depression, and anxiety. This is a bigger font version of the same. And so if you think about this complex part here, sorry, I should have put this way, in this part of the arrow, I think it will not come as a surprise that also this part of the arrow is much more complex. And in fact, in the standards, we can see that there are many, you see them all in this table, interventions that have been found to be effective in preventing drug use and in preventing other risky behaviors. And you can have intervention in all ages. You can see up here, childhood, adolescence, adulthood, and in many, many settings: school, families, community, the workplace, and the health sector. The good news is, of course, that as we know that the vulnerability factors are at the basis not only of drug use, but many other risky behaviors, as I was telling you before, now we know that if you do these interventions, so evidence-based intervention, you prevent many risky behaviors. You can achieve less mental health problem, less risky sexual behavior, better school performance, less violent behavior and delinquency, in addition to less substance and drug use. Ain't that great? And then, of course, because basically what we are doing is to support the healthy and safe development of children and youth and the well-being of adults. And what is great is also that we are saving money, and that evidence-based prevention is in fact cost-effective. And I'm showing to you an old, safe and conservative calculations that are calculations that show a much bigger rate of saving for prevention, but I've chosen to be conservative and not to exaggerate, but still to give you this strong indication that if you invest in evidence-based prevention, you're not only investing in the future of children and youth, which is already great by itself, but you're also saving money, and for each dollar invested, you save at least 10. And so this was our world before COVID, right? We thought, that's it, this is our job. And many of you, we have collaborated together in really trying to move people from this maybe black column here, written in black, where they're using non-evidence-based prevention strategies, maybe strategies that are not in the standards, or strategies that are in the standards but are implemented in a way that is connected, has been shown to be connected to negative outcomes, and really move them here to the evidence-informed and evidence-based kind of interventions. And maybe some of you know a very old British sitcom called Fawlty Towers, in which there is, in one episode, the character of a very sweet, very funny, completely incompetent builder who was saying, referring to a very difficult building job, easy, lick of paint, half an hour, done. And I'm not saying that our word was lick of paint, half an hour, done, but we thought we had a good understanding of where we wanted to go and how you know, moving people from using mostly evidence-based strategies, which are here represented in green, really could change the world and could change the life of children, youth, communities for the better. And we still believe that. It's just then COVID happened. And from this nice plan that we had, we were feeling more like this little cat in the dark. What are we going to do here? Where do we go with our evidence-based prevention, right? And so, as I was saying, what I'm presenting to you is our attempt, and we have chosen to go one particular way, but I know that in front of you, you have presentation from a much wider variety of speakers that will introduce much diverse and additional approaches that I'm really, really looking forward to hear. Still, thank you for the opportunity of telling you what we have been trying to do. And our attempt is really to go back to the issue of parents. And I've shown you this graph already, and how parents matter, and how adverse child experiences interact with inequality. And I really do not believe that COVID has shown that inequality exists. I think many of us were already very, very cognizant of the fact that inequality has enormous implication on health outcomes. But I think it is true to say that COVID has, you know, make this more apparent to more people. And so, and we will see, and this is where we started looking at. Another thing that I wanted to show you is, again, something similar to this graph about underlining the importance of parents, but here it really underlines the importance of the quality of parenting and the importance of parental warmth. Yes, monitoring is very effective and is needed, but the best results, which are here, is when good monitoring is goes hand in hand with parental warmth and a warm and positive way of parenting. And of course, we have been, how can I say, knowing this for a long, long time. And that is why UNODC has been active in the field of parenting skill programs for a long, long time. And this is also another additional reason why we decided to develop things in this field. So in terms of parenting programs, what I'm talking about are programs that help parents be better parents in very simple and funny ways, no lectures, no jargons, activities together, and that really work on family bonding, so the attachment between the parents and the children, that parental warmth that I was talking to you about, and of course gives practical tips to parents on how to monitor and be involved in the lives of their children, and provide discipline, but in a positive and developmentally appropriate and effective way. And UNODC, there are many programs. We have developed 2 programs, Strong Families and Families United, that are in the public domain. They are at the disposal of everybody. One is for settings that are very, very poor in resources, and one is more for all families. And by using these programs and many of the other evidence-based programs that exist around the world, we knew that this kind of programs can be effective in very difficult circumstances. So these are programs not only for the good times. We knew that these programs are effective in very violent communities. These are the results from our work in Montenegro, Dominican Republic, Guatemala, and Honduras. Honduras being a country with very high rates of violence. We knew that these programs can be effective for very poor communities, and as this is from our work in Iran, in Brazil, and Uzbekistan, we know that these programs can be effective for displaced populations. This is refugees, Afghani refugees, both in Afghanistan and in reception service in Serbia, showing how even in these difficult circumstances, these programs can improve the behavior of children. And whether in difficult situations or not, we know that family-based prevention is more consistently effective in benefiting both girls and boys. And of course, we have the endorsement of the World Health Organization that says that family-based prevention is effective in promoting mental health, preventing violence, particularly youth violence, and preventing child maltreatment. And so all of these together came to our mind when we started seeing, with the COVID-19 pandemic, increasing reports of higher rates of stress and domestic violence, particularly linked to economic insecurity and being out of school. So I'm giving you some data from Save the Children that had undertaken a survey all over the world and really showed how children were reporting increased rates of violence at home, particularly when A, their family had lost their income. So again, the effects of inequality and socioeconomic marginalization. And B, where when the schools were closed and that protective environment was not there anymore, and the children were only stuck at home. So this report is very aptly called Protected Generation, and this is really what we set out to do with our tools. So what we did was to develop tools for parents in all languages. We have a leaflet and a booklet. The leaflet is has been translated in more than 40 languages, but even the booklet, we have more than 10 languages, and they are available here at our website. They're very easy to find. And as you can see in these resources, we talk to parents and caregivers about what they might experiencing, what they can do, what the children might be experiencing, and give very practical and basic tips on how to cope with this difficult situation in a way that strengthens the resilience of children and families, and does not fall into negative coping mechanism. And you might think, you know, Giovanna, yes, this was very well and nice. It's a bit of an anticlimax, right? I mean, you think these are things that are so important, and what do? You create a leaflet and a booklet. Well, I mean, we have to start somewhere, and but there are two pieces of evidence which I'm not able to show you here because I didn't manage to create the slide, but I want to talk to you about anyway, and I can share the study later. There are two pieces of evidence that I take a lot of comfort on. Once we did a study in refugee camps. These were Syrian refugees in Turkey, extremely difficult situation. And we created a book, a leaflet, similar to the one that you have seen, providing tips to parents on how to take care of their children, very similar to what we have done in a very difficult situation. We also attached a short questionnaire and a pen. And where did we put all of this? We put them in the bags of bread that were being distributed in the refugee camp. And we were hoping that a few of the parents might read the leaflet and maybe some of them would reply to us with a little questionnaire. We had a 70% 70 response rate. I think this is unprecedented in many surveys. Parents did read the leaflet, did find it relevant, and were trying to apply to the best of their abilities in that difficult situation the tips that I had found in the leaflet. And so I'm very positive that yes, it is a small thing, but where you provide relevant information to parents, they will try to use it because they know that they need it and they want their best for their children. In another study, we had provided parents in a slum area in Panama one session of 1 hour lecture, not interactive, not attractive. All the things that I've just said, it was really, really, really basic. And still in that randomized controlled trials, this did have a positive effect and did improve the way parents were parenting. So I know that it's a small step and we are trying to use this, disseminate these resources with our partner organizations all over the world. I invite you to use them as well, because we know that parents do need them and will try their best to use them, even if it's such a basic piece of information such as a leaflet. And we also know that there are parents in very difficult circumstances, and I'm thinking about refugee camps, I'm thinking about slum areas that are extremely crowded, and we have developed a resource just for them. What else? We also try to appeal to maybe people that have a bit more resources and that have an online connection with the new Listen First campaign. And we have a new website in English, French, and Spanish for now, but we are trying to do our best to, of course, to translate it in all of the UN languages, but also beyond that, of course. And we are producing 10 new videos and fact sheets for parents. So each video has a fact sheet. And I think we have a little bit of time maybe to show you the videos that are available for now. I would like to show them to you. They're super, super brief, but they're happy and positive. And I really hope they give you an idea of how we can support parents all over the world to really cope with this unprecedented situation in a positive way. So if you give me 2 seconds, I'm challenging my technological abilities once more and try to show you this. I hope it works. So I hope I have given you an idea and I have inspired you to go and check out our videos and participate on social media. We have 5 more videos to come, and each one has its own fact sheet that gives not only the science, but funny and happy tips that would make the life of families happier and more united and easier, also in these very difficult times. And as I was saying, this is our the other thing that we are trying to do, but this is still a bit of a, how can I say, at the planning stage. We are connecting to in Jordan and in Rwanda with an organization that is providing an app for parents to remind them about vaccinating their children. And we are hoping to be able to provide tips for parents on parenting through that same app. And I hope to be able very soon to be able to present this work to you as well. And as I was saying, this has been our attempt at addressing the challenges of the pandemic, particularly the stresses on families, on parents, and the end of inequalities. But I'm very, very much looking forward to hearing about your experiences, because I think that in reality, our work in promoting the healthy and safe development of children and youth and the well-being of adults is actually more relevant than ever. And so I thank you again for the opportunity, and at your disposal should you want to exchange ideas and ask questions. But above all, I'm really looking forward to hearing about your great practices and experiences, and to join forces together to help children, families, and communities in the world, anywhere, everywhere, to not only to cope, but to thrive. Thank you so very much.
Thank you. What a great presentation and such great information. And I just really love all those videos and love the focus on parents. I think that for those of us working in the prevention field, when we go out into the communities, one of the questions always from adults, whether they're parents or just people who have youth in their life, is what can we do? And these videos show them exactly what they can do without having to be the know-all person on the impacts of drugs. These are just great things, showing affection, having family activities, doing physical activities together. They're perfect. And it helps build protective factors, which is what we are in the business of doing. So absolutely wonderful. We did have a couple questions. One quick, easy one for you are probably, are the pamphlets available in print for distribution?
Physical print, no, but they are available for you to grab and print as much as you want. And as I said, we are trying to produce as many languages as possible. If we are not covering one of the languages you are interested in, please get in touch and let's see how together we can join forces to translate them together. Perfect.
And then all the videos can be shared from the YouTube channel.
Of course, of course, they are in the public domain. The more sharing, the merrier. If you remember to use the tags, the listen first and the science of care, we would love it, because it helps build that movement around it.
Absolutely. And then another question came in. It said, can parenting programs addressing parents of older youth and teens make a difference in outcomes? So I guess some of these were focused on the more younger kids. What about programs for older adolescents?
That is actually a very good question. The evidence I have to say, goes to early adolescence. So I've seen effectiveness until the kids are around 12, 13, already 14 is pushing it a bit. Older prevention programs I have not seen. I would really welcome the opportunity to be proven wrong. If anybody knows of any effective program, please do get in contact, and so that we can revise the evidence. I'm telling you what I know right now. For older adolescents, what tends to happen is that kids get maybe a bit in trouble, maybe they start using. Thankfully, they are not dependent yet. And that's where programs like family therapy can kick in and are very effective. So, of course, this is not exactly what the question was asking, but this is what the situation is.
Okay. And then one other question that came through that I saw, and hopefully I didn't miss any, was what can be done if you work with adolescents? So I guess it's kind of on the same.
It's similar, yeah. I would go back. I would certainly try to move earlier in terms of prevention. And if there are adolescents, I think that still there is not good evidence, but I think I would still make a good case to work with parents to find together effective, positive ways of dealing with their adolescents. I think that would not harm, that might only help. And then for very difficult cases, in terms of family dynamic, I would try to move people to services of family therapy.
Okay, and then we have time for one more, and I've got one more here in the queue, and it says, how would you address parents, perhaps generations of them, that have experienced adverse childhood experiences themselves to learn how to parent effectively?
That is, okay, the short question is, I don't know. The short answer is really, I don't know. I think that the bit longer answer is what we have found is that parents in general benefit, and their parenting improves, and the entire family benefits from that. There will be parents for which being involved in this kind of programs opens up issues. We often see parents, taking aside the facilitator and reporting domestic abuse, or maybe a history of trauma. This is where the parenting skill program, cannot really help. This is not what it is designed for, but a prevention system would have that possibility in place to refer this parent to a service that addresses this. This is still far from reality, right? I know that I am describing an ideal situation, but it is an ideal situation for which we should strive for, because everybody will benefit, and we can really help to break that cycle of trauma that can be, unfortunately, remain unbroken for many generations if we don't do something about it.
Perfect. All right, well, thank you so much. And I know for us at Drug Free America Foundation, we will get on social media and definitely share those videos. I think that they're amazing, and I hope everybody else will too. And thank you so much for your time. And we just really appreciate the presentation. And I know we don't have sound on for everybody, but I'm sure everybody is clapping, and we just really are thankful to have you here with us today.
Thank you, and looking forward to staying on and hear the other amazing presentations. So thanks. Thank you, Amy, for organizing everything.
Thank you. Okay, so now it's time for our first break. We will break for 10 minutes and then come back for our first panel. So Carlton will be welcoming you back from our break. I think if we have this set up properly, you should see a timer that will pop up on the screen to let you know. Oh, there it is. And so get up, stretch, get a drink of water, do some physical activity, and we will see you back in 9 minutes and 50 seconds. Thank you.
My, that countdown had me feeling like something magnificent was about to happen. And hopefully you feel the same as well. My goodness. Well, thank you all so very, very much. Thank you all for joining us today. We are off to a wonderful start. I want to add my gratitude, my thanks to Giovanna for an extraordinary presentation. Thank you very, very much for that extraordinary information that I'm sure everyone appreciated and was able to gain a great deal from. So thank you all. It is my great, great, great pleasure and honor to be able to facilitate the next conversation with everyone. And to be able to do so is really to build on the wonderful foundation that Giovanna laid for us. As you all are extraordinarily aware, before the pandemic came across, we were already dealing with multiple crises across the world. Whether we were talking about the opioid crisis and the rising vaping issues in the US, or issues such as the challenges with tramadol in Western Africa, or the rising cases of heroin and cocaine misuse in the European states. We were already dealing with crises that affected addiction across our world. And new challenges have contributed to taking an additional toll on us. Dealing with virtual homeschooling, for example, or concerns about safety, looking at financial hardships and issues and challenges that has laid waste across our communities, have really provided preventionists with unique challenges of rethinking and relooking at what these issues have to deal with as we are looking at how to take some of the practices and the science that Giovanna introduced and apply them to our communities. Well, I'm honored to introduce three extraordinary leaders from different parts of the world to provide their perspective and how they've been able to think through looking at the issues and the challenges that are relevant to our work. And so I will introduce each of them now, and then provide them all with an opportunity to provide their wonderful presentations. We will start with Mr. Antonio Jesús Molina Fernández. He has a clinical and social psychologist background, as well as a social anthropologist. He is the assistant professor of social, clinical, and epidemiological aspects of addictive behaviors at UCM in Madrid. And has worked for more than 20 years as a practitioner, a psychologist and a director in addictive behavior programs, and has been either a manager or a trainer or a researcher or an evaluator or a coordinator in different national and international projects with extraordinary organizations like Dianova and UNODC. He has extraordinary background and great work, and we're looking forward to hearing from him. After Antonio speaks, we will move from Europe to East Africa and hear from our wonderful friend, Anna Nabulya. Anna is the Deputy Director at the Uganda Youth Development Link and oversees all programs and partners related to trafficking in persons and safe migration and sexual exploitation and abuse of children. She has 17 years experience mobilizing resources, designing and coordinating projects, addressing socioeconomic and socio-behavioral rehabilitation and reintegration of children and young people aged 10 to 25 years affected by sexual exploitation, alcohol, drugs, and substance abuse issues and challenges. We are extraordinarily honored to have her. And then we will move from East Africa into the US and hear from Chuck Daugherty. And Chuck Daugherty is the Executive Director for ACT Missouri, Missouri's statewide training and resource center. He has over 30 years experience providing prevention, intervention, treatment, and recovery support to at-risk youth, adolescents, and special needs populations in community-based and clinical settings. Prior to working at ACT Missouri, he worked for the Substance Abuse and Mental Health Services Administration, or SAMHSA, Southwest Prevention Center, and Southwest Center for the Application of Prevention Technologies. As a respected preventionist with a history of developing innovative and sustainable programming and service provision to communities of all settings, he has presented numerous times across the field, across the prevention field. It is our extreme pleasure to have each of these extraordinary leaders to provide their presentation to us. Antonio, I'm going to turn it over to you. Each of our presenters will have 15 minutes to provide and offer their perspective from their communities. And then after that, we will have an opportunity for some Q&A, and I'm looking forward to that. And so, Antonio, the floor is now yours. You're gonna.
Thank you very much, dear Carlton. Really, I'm totally honored to be here today. It's a real pleasure to be in this forum with these wonderful speakers, with all this topic that we have, would like to work on. I think it's an amazing possibility, amazing chance for me. So I really really appreciate, and I'm a little bit, because after the presentation of Giovanna Campello, that she is the Chief of Prevention of UNODC, so it has been an amazing and a very inspiring presentation. So I'm going to talk about what are we doing and how are we adapting and readapting the strategy, because as Carlton said before, I'm professor in university, but I have been also practitioner for 20 years. And right now my position is that I try to develop strategic alliances between the university and NGOs for the development, the research, the development and the evaluation of prevention programs and early intervention programs in specific topics, because we consider that it is necessary, as Dr. Campello said before, that it's necessary to use evidence-based practices, to use practices that has got the possibility to be assessed, to be contrasted, to be adapted, to be modified, and also to can be evolutioned for the people that need these different practices, and not to use the same programs that we started to use at the beginning of this century, trying to make the adaptations to the new realities that we have got. And COVID-19 for sure has been a new reality. So we need to assess what we are doing, and we need also to adapt what we are doing to our new realities. So as I said before, I would like to consider that we have got a strategic alliance between the university and Dianova. What I'm going to express is how are we developing this alliance. Our background is fundamentally COVID-19 crisis, that we know that has increased several aspects, especially several psychological and also psychosocial aspects, not only psychological, and also psychological aspects, and a problem that normally was not included into the addictive behaviors problem. When we're talking about substance abuse fundamentally, that is the control of technological tools and the technological behaviors. We know that technologies and non-substance addictive behaviors can be a problem, but now we have got never ever before so exposition to these tools, and we have to understand what are the risks that may have linked this exposure to these tools, and how can be connected with other kind of risks, to other risk behaviors and other addictive behaviors risk, like happens with the use of smoking, the use of cocaine, use of video games, the use of alcohol and cannabis. So we want to understand how has changed the COVID-19 crisis to our situation, talking about addictive behaviors, not only substance abuse, or substance use or early problems with substances, about addictive behaviors, and how can we adapt what we are doing to this reality. We have used a syndemic perspective. So we have considered that we are talking about a health problem, we are talking about a public health problem like addictive behaviors, but I have a public health problems that is conditioned by several other aspects, like it happened with biological social interaction. In this case, the social interaction is very clear. Is now we have suffered lockdown, we have decreased some kind of social context, social context supposed to be, and also we are finding that is increasing the difficulties and the complexities to access to different resources and to different possibilities, and these difficulties are different from one group to the other. So we want to understand what is the influence of several topics like poverty, like structural violence, like addictive behaviors in this situation, in this COVID-19 situation. Now we're finding that we have a concentration of problems. We can talk about that we have one problem with substances, one problem with one substance, like it happened, for example, in Europe during the decade of the 80s with the epidemic of the heroin, that it was the main substance abuse and the main problematic substance in that moment. Now we have got a concentration of problems, and the interaction between these health problems and social factors are the core concept of this perspective of syndemia. This is different when we talk about syndemia. That's why I have included it, this sentence into the presentation. It's different when we talk about comorbidity that when we talk about syndemia, because comorbidity interaction is more focused in this interaction between diagnosis. But syndemia focuses in the communities and the factors that increase the negative consequences of these problems for the communities. So we prefer to work with the groups and with the communities much more than with the syndromes and disorders and these clinical aspects or concepts. So using this perspective, we thought, we're still thinking that the strategy in prevention, we have other kind of activities much more linked with recovery, which are linked with harm reduction even. We have different, several specific programs for harm reduction. So talking about prevention strategy, we developed 4 lines. One line that was much more about research, especially the psychosocial consequences, much more than the clinical consequences, or much more than the neurobiological or genetic aspects. What we want to find are the psychosocial consequences of the combination of COVID-19 and the influence in addictive behaviors and in early intervention and early detection of addictive behaviors. Second one is about the direct intervention, that we use the perspective of early intervention fundamentally. We also have got intervention for a specific group, but fundamentally work with in early intervention and the increase of use of social media and how can we work with the social media in the intervention. Third strategic line was about evaluation. We consider that the assessment of the practices and the programs that we are developing is fundamental. And we also consider that it's necessary to collect, to compile good practices and to share these practices with other colleagues and with other organizations and institutions that, and to understand and to compare what we are doing and what we are doing well and what we can do better in this case. And the third one is about dissemination, especially divulgation activities about main prevention topics. This line, we have been focused not only because of COVID-19 crisis, we have been focused about the risk of the cannabis use, especially this perspective about cannabis regulation and possible consequences of cannabis regulation in health, in social, also in policies, but fundamentally talking about prevention in health and social, and the influence of misuse of social media in these cases. So, talking about research, talking about the psychosocial consequences of COVID-19 crisis, especially for young population, in risk. So we are involved in a project that is the research project Psychological Effects of COVID-19 Lockdown. The coordinator is Dr. Joanna from the University Cooperative of Colombia. And we are involved, and both organizations are involved. As I said before, we are considering this situation as an opportunity to develop a strategic alliance, and both organizations are involved. Facultad de Psicología, the Universidad Complutense in Madrid, the Faculty of Psychology of University Complutense of Madrid. There is the institution that I belong now. Is the academic part of the connection with the project. Asociación Dianova España, Dianova NGO, is more the intervention part, the part of early intervention of the project. And we are working together analyzing this situation in different countries, in Colombia, Italy, Brazil, Mexico, and Spain. General aim of the project is to analyze psychological effects of COVID-19 lockdown, so it's a much more ambitious project than a prevention project. But the part that we are more involved with is the part about to assess the impact of lockdown in specific groups, and especially in young users of addictive behaviors, in young and adult people, and addictive behavior treatment users. For this about the prevention, we are analyzing especially the influence of the lockdown and the psychological effects of the lockdown in the use of addictive behaviors of young population. So what we are finding is that the compulsory use of internet, that it was high, has been increased during the crisis, but not significantly increases. So the data has not been that the evolution has been significantly, but the previous data was very, very high, in fact. The use of e-cigars, Juuls or similars, has increased a lot during this time. That is a problem that maybe we are not talking a lot about it, but now it's becoming a public health problem, because we're talking about people between 14 and 18 years. These data are from people between 18 and 14 years, so are not data for adult population. So we are talking about that the use of e-cigars in young population has been increased last year. Gambling is other behavior that has increased last years and has increased during the COVID crisis. The use of gambling has been increased, especially in male population, and especially in student population, in people that is a student right now. And e-sports, that was very popular, and also video gaming can be considered as a problem or disorder. The prevalence of playing video gaming has increased, but is higher. In 14 years, that is slowly decreasing until the 18 years. So we think that can be temporary lapse of use of video games, or compulsory use of video games, sorry, and then it can decrease sometimes. So the conclusions of the first stage of this study, because now we are going to develop the second stage of the study, we are now analyzing more data in several groups, but also with this group, is that fundamentally the abuse of this behavior has got a functionalist pattern right now. So we can find that what we are finding is that there is a group, a significant group, that is not a very big group, but is very relevant, that have got a lot of risk behaviors. So they have got higher levels of anxiety, they have got higher fear perception, they have got higher compulsory use of social media, higher compulsory use of vapors or e-cigars, higher compulsory use of video games, also including gambling and misuse of social media. So we find that we are talking about that the general young population don't present a problem with the use of addictive behaviors, but there is a group, a numerous group, not the higher group, but a consistent group that has got a lot of different risk behaviors. So what we have to do, as said Dr. Campello before, is to develop programs that not only work with the use of drugs, of the use of even non-substance, with the use of other technological behaviors, for example. We have to identify what are the risk behaviors that have got these people. And we have to work with several aspects of these risk behaviors. So it's necessary to implement strategies changing our perception, trying to find different risk behaviors, not only the use of drugs, or the use of misuse of technology, trying to find a different perspective, for example, it's a different risk behavior, risk situations, as irrational ideas, or an improper management or emotional management that is also connected with this group, or as I said before, high level of anxiety. And we have to identify it, and we have to work with it in early detection and early intervention, trying to improve the intervention about this problem if we want to use successful strategies to work with this problem. So this is about the research. As I said before, we are still working in this topic. We have been also working in other topic that I'm going to say when we will talk about dissemination, that is about cannabis use. The cannabis use was a study that we were developing since 2019. We have been developing the study during the COVID-19 crisis, but it's not designed for COVID-19 crisis or influenced by COVID-19 crisis. But also we have done a few activities connected with this study, because as you know, cannabis use and these myths and legends about cannabis regulation and recreational cannabis regulation can increase also the risk, and can create a public health problem for several populations. About early intervention, what we have done is a handbook, a manual of early intervention. A handbook of early intervention that is online. You can find it here in this link. You can find it in this link. And what we have done is a handbook of intervention with standards of intervention, using several standards of intervention for specific groups. Not talking only about substances, because what we want to analyze are several risk behaviors, as said before, and also including into the manual of early intervention, including the use of social media for the screening and for detention, not only the social media as a problem, also social media as a solution for the intervention, and the participation of the family as a stakeholder in the program, using not therapy for families, that's sometimes what we're doing, using much more strategies for focus on solutions, trying to help the family about what they can do and how they can do the situation with supervision and with counseling by our technicians in Dianova. So what we have done.
Leo, you have 2 minutes.
2
minutes.
Thank you. So you can find the manual here in the link. About evaluation, assessment of practices and good practices collection, we have also developed a monitoring center for a specific center for minors. So what we have done is trying to assess what we are doing with the young population, and trying to find what are the weaknesses and what are the strengths of this intervention, and using quality standards of intervention. So we have developed a monitoring system, and we are making a continuous reports about the strengths of weaknesses of the developed systems. And also we have here a transfer of new good practices that we are doing, that we have also developed this year, trying to show what we have done and what we are doing to other organizations and other institutions that are working in the same sector, and trying to share this experience between us. And about dissemination and divulgation, and with this I'm going to finish with conclusions. That's only what I need. We are making, in collaboration with the University for Sure, webinars and seminars talking about myths and legends about international regulation of cannabis consumption. This report is possible also to find in English and Spanish. All the materials are in English and Spanish. You can make it the choice of language that you prefer, and you can find all the information also in the Dianova website. There's the link. So we are making this webinar in collaboration with my department about myths and legends of regulation, international regulation of cannabis consumption, trying to clarify what are the public health risks and the main possible consequences of a global regulation of cannabis. And all this information and a lot of noise that now we are receiving talking about the regulation of cannabis, and not being very dramatic, but being very clear about the possible consequences that may have, that can be an enormous increase about the use of cannabis in groups, in risk groups, and also in groups that can increase the risk by the use of cannabis. So the conclusions that we have find in this strategy is that the fear is not a good strategy when we want to avoid risk behaviors. It seems to be better a combination of research plus early intervention plus the evaluation of the practice that we are doing. It is necessary to review the design of prevention programs and other addictive behavior treatments. We're talking about prevention, but it's necessary also to make a review about other addictive behavior treatments, recovery, harm reduction, and the specific training of professional staff to adapt the prevention programs to young people's specificities, to actual young people's specificities. Now we have got a young population living in a special situation with special capacities and skills and that need a specific attendance, and we have to offer this attendance. And not to consider social media or internet like problems, we are finding that they can be a solution. So the use of internet screening and media could be highly recommended for this population, because also it's a direct and fast way to access to young populations. So a lot of thanks for your attention. As I said before, I'm totally honored to be here. And if you have any kind of question, don't hesitate to make me. Thank you very much. I'm in time, Carlton?
And perfectly. Antonio, thank you so very much for an extraordinary presentation. Thank you for reminding us about the fact that our work is within a syndemic context, that we have to consider those things, and the notion of recognizing the importance and the relationship of your 3 or 4 areas, research, early intervention, evaluation, and dissemination, as a way of thinking through how we practically do these things. We're looking forward to the conversation with you after our other 2 presenters. And so everyone, we're going to move from Spain to East Africa, and specifically Uganda, and our great friend, Anna. Anna, go ahead. The floor is yours, and we're looking forward to your presentation.
Thank you, Carlton. Thank you, everyone who is attending, and thank you, Drug Free America Foundation, for inviting me as a panelist to share the experiences of Uganda Youth Development Link. To kickstart this discussion and to kickstart the sharing of our experiences of the pandemic and how it has impacted our work, I'll start by sharing with you what Uganda Youth Development Link is, or sometimes that we call UDEL, in a short form, and I know I'll be making a lot of referrals to the term UDEL, but it will mean the long form of Uganda Youth Development Link. This is a non-government organization that is basically operating in Uganda for the last 27 years, and we are working mainly with young people within the ages of 15 to 24 years, and our areas of focus are mainly alcohol, drug, and substance abuse prevention, commercial sexual exploitation of children, prevention of child trafficking, and also child labor issues. And then we're also looking a lot at sexual reproductive health and HIV/AIDS, and also doing quite a number of researches in all these 6 fields, in all the 5 fields that UDEL works with.
Hello?
Anna, are you there?
Oh, sorry.
In the cases, and we have seen them instituting lockdowns, we've seen curfews, we've seen closure of schools, we've seen nightclubs and the nightlife being shut down. But all this has had consequences on the economy of Uganda, but also on the work that we do as UDEL, because we've seen quite an increase in economic strain, where we've seen lots of businesses collapse. We've seen people go without food. We've seen people being laid off work. We've seen a lot of people lose their employment. and businesses capital closing and collapsing. We've seen quite an increase in numbers of young people who are abusing alcohol and drugs, because now it's being done underground and not in the bars or in the nightclubs or in the restaurants like it was earlier done. So it's now being done underground. People are increasingly using and abusing alcohol in their homes. We are seeing sexual violence on the increase, and also quite a number of young people who are engaging in crime and theft for survival. But we've also seen an increase in numbers of young people that are being arrested and murdered. Now, the pandemic has also affected the young people that we work with. We do a lot of socioeconomic strengthening for young people, and this is how it has affected most of their businesses. We've seen the young entrepreneurs' businesses collapse because they don't have enough capital to sustain the businesses. We've seen issues that have to deal with failure of businesses because the stocks are rotting, or because they are getting spoiled or expiring within the businesses. We are seeing a lot of depression, anxiety, stress, and trauma. We are also seeing that the young entrepreneurs are not able to pay back loans that they have already acquired, and some are behind on their loan schedules. We've seen enterprises also close down, but also the employees or the employers themselves have also been affected because they have to lay off some of the young people. We are seeing some of the employers not paying salaries and young people not receiving salaries. We've seen them being laid off work, but we've also seen young people increasingly staying over at the workplaces with no increased pay, sleeping over within the workplaces with no increased pay or support systems in place to support them in the new conditions that they are living in. When it comes to some of the young people that are in the saving groups that we've created in our work, we are seeing that many of them are no longer saving. The saving groups are collapsing. So that means that there's no income or source of income. We are seeing a low loan repayment. We are seeing members within the saving groups having no security because they had to use up most of the capital and most of their savings during the lockdowns. And we've also seen the groups disbursing and not being able to meet, which has affected quite a big number of young people and has increasingly led to them engaging more into crime and other risk behaviors that are exposing them to alcohol and drugs and also sexual exploitation. When you look at Uganda, this is something that I pulled out of the Global Initiative Against Transnational Organized Crime. COVID-19 has exacerbated the human trafficking situations in Uganda. We are seeing an increased number of people as potential targets and victims of human trafficking. We are also seeing an increased number of people within Uganda that are in the formal and informal sectors, increasingly trying to find work, increasingly trying to find survival. And so that means we are having a huge supply around the informal sector and the formal sector, but we're also increasingly having more young people that are on demand for businesses or for criminal gangs and other activities. We are seeing an increase in child predators demanding more children online or trying to lure more children online, because now that's the biggest major source of communication. And also during the lockdown, many people relied on the internet for information, for services, for any kind of closure, because many of them were not going to work and everybody was enclosed within their homes. Where you see children are staying at home more and not in school, it means that most of the social protection factors have also been damaged in some way or another, which has increased situations of online child sexual exploitation. We've seen forced labor within the homes and within the different communities. We've seen an increase in sex trafficking, which has exacerbated the issues of human trafficking. This further tells us that ILO is estimating that we may be having an increase in the number of young people who will be, we're going to have an increase in the number of young people who are going to enter into poverty. And it's estimated that it should be around 25 million that will be entering into poverty. Now, when you look at the general situation in Uganda when it comes to reports on sexual exploitation that have been reported to the police during the COVID-19 period, we are seeing an increase in the number of sexual gender-based violence cases. And of course, this is also exacerbated by alcohol and drug use, which is on the increase. And also because we are seeing a lot of employers, and we are seeing a lot of people who are constrained because they can't provide for their families or for their homes. So this has quite increased the elements on sexual gender violence in the homes, or vulnerabilities to sexual gender violences. And the cases are quite increasing. If you can see the cases there that have been reported in just 2020, that's around 16,000 cases. But that means that on average, every month from January to June, we are having 2,700 cases that are being reported on sexual gender violence in Uganda. But then when we see the response side, because most of the social services are down, we are seeing that most of the cases are not reported and they don't end up in court, or we don't end up securing any convictions. Like you see there, we have few cases that are being convicted, and it becomes very, very difficult for us to survive. So when we go back into Uganda Youth Development Link's work, these are the few cases that have been reported to us since the COVID-19 period. And when you look at gender-based violence, we have over 8,000 young people who have reported gender-based violence this year. And this is all forms of violence, emotional, physical, economic, but all the 8,300 out of the 15,000 young people that we worked, the 56,000 young people that we worked with in this year, we have seen quite a huge number of cases that are actually sexual gender-based violence. How many of these have been using alcohol? In the last 3 years, we've been trying to look at all the young people that have come through our youth drop-in centers and safe spaces. And from the 59,000 young people that we have received, we've gotten half of these, 52%, abusing alcohol and drugs, which was quite worrying for us as an organization, and also told us a lot of issues on why we need to do a lot of prevention work with the young people before they get into adolescence stage, or before they get into the stage of emerging adults. And we've seen, of course, quite a number of effects with alcohol and drugs. We've seen rapes, we've seen partner violence, we've seen sexually transmitted diseases, among others that have affected young people who have been abusing drugs in those categories within our safe spaces. So what have we done as an organization? We have tried to put up a lot of support in terms of prevention work. One of the key issues that we realized during the lockdowns was that many young people did not have food due to the lost businesses, the collapsed businesses, lack of income, not having enough savings. So the food was a key factor for us to address during COVID-19 to help reduce on the numbers of young people that were engaging in crime for survival or to put food on their tables. We designed quite a number of risk communication and mitigation messages through posters, through using community mobile radios. We mobilized cash transfers and supported young people with emergency funds to help them survive or meet their most basic needs. We also put up a program to support young people come up with artisanal face masks that they could sell at a small fee and earn an income to support their families and friends. But we also looked at the protection gears because it was very difficult for them to even buy soap. And yet most of the prevention or mitigation strategies were encouraging people to wash their hands every minute, but they couldn't wash their hands because they couldn't even afford to buy soap. So we provided most of the protection gears and also sanitary towels for young people that were affected during the COVID-19 period. And of course, we partnered with quite a number of local leaders and the local leadership within the areas where we work. We work closely with the police. We work closely with the the COVID-19 task forces and surveillance teams that were within the communities. And this enabled us to, create quite a number of strides, or get a number of strides in the COVID-19 period, because we were able to reach out to 1,500 young people during the lockdown with different services, or different social services, because during the lockdown, social services were not an essential service. So most of the social workers and the social and people who were dealing in the social protection area had to also stay home during the lockdown. So that means there was a collapse in actual services for young people. And the fact that we were able to link up with the local leadership was quite easy for us to continue providing social services, but also reaching out to families that needed this kind of support, especially those that were being affected by gender-based violence, mental health care, or needed, referrals for services in terms of alcohol, drugs, and substance abuse. I talked about the community surveillance and sensitization on risk communication, mitigation, and referral. And we're doing this closely with the task force and community surveillance teams and the local leaderships within the areas. Like you can see some of the pictures there are basically showing what we were doing with young people in the different communities during the lockdown and during the pandemic. These are some of the communication messages that we developed to help young people understand what COVID-19 was, because many of those that we were reaching out to using our phone numbers and using our peer educator network, many of them were telling us, we don't even understand what this COVID-19 is. We are just starving and they are telling us COVID-19, wash your hands, do this. And it was quite difficult for them to comprehend. It was a lot of stress on their side, a lot of depression there. So these materials helped them understand what COVID-19 was and also how they could mitigate it, but also issues on gender-based violence and how they could address this. We did quite a number of work around food support, which I talked about earlier. And this helps them cope with issues on sexual violence, but also the stress that they were facing and not turning into dubious, risky behaviors to survive. We had quite a number of cash transfers that we mobilized to support young people, continue surviving during the lockdown. So we were basically, the lockdown helped us come up with multiple strategies that would help us reach young people with services and not get them going back into the risky behaviors like abusing alcohol and drugs that they were doing before they joined the UNODC Rehabilitation program. So it basically helped us continue, have a continuity of our social services to the young people, but also reach out to quite a number of young people with services. These are some of the artisanal face masks that the young people were making for sale. And of course, these were certified by the National Standards Bureau within Uganda. And so it was official and it was legal for young people to continue producing and making face masks for sale. We also had a chance to do a lot of HIV.
You have 2 more minutes.
Yes,
you have 2 minutes?
2 more minutes, okay, thank you. I'm actually almost there. We had an opportunity to do HIV, GBV, and alcohol and drug abuse screening and referral for assistance, of course, using our community networks, the peer networks, and also using the local leader relationships that we had created with the police that had permitted us to continue providing social services to young people. And then we also continued with sessions, interventions on behavioral change, but also improving communications between parents and the children, but also young people using the stepping stones and the Synovio approaches to help them create more resilience and also build positive assets during the lockdown, and continue also, practicing positive, making more healthy decisions in terms of survival. And then we also did a lot of socioeconomic strengthening. And we did this in a smart way because by then we were not allowed to have young people in big groups. So our partnerships with the local leadership and the police allowed us to have young people trained in groups of 5 to 10 young people within their households at household level. So we're able to provide short-term skills and also those long-term skills that could enable them acquire income, especially in what we call, what the government had highlighted as essential services, which was mainly food and face masks, and also gardening. So they were producing some vegetables and selling them out to different communities and earning an income. And that helped reduce on the frustration. And of course, with our continued peer-to-peer support, we were able to have success in most of the work that we did during the COVID-19 lockdown with young people who stayed safe and stayed away from alcohol and drugs, and also stayed away from sexual exploitation or any risk factors that would expose them to exploitation. So we want to thank everyone who is listening here, and we want to thank all our partners and our donors and the Drug Free America Foundation for allowing us to share what we have done during the rapid response. Thank you. Over to you, Carlton.
Wonderful, wonderful. Thank you so much. You can stop sharing your screen. Thank you very, very much for that remarkable presentation and the great work that you all are doing there at UDO. Rajesh Kaseye, your executive director, is an extraordinary leader out there with you all. Thank you for reminding us of the interplay of a variety of issues such as gender-based violence and substance use disorder challenges in your community, and that while we are all going through the pandemic, we're not all going through it equally, and some of the real significant challenges that you are addressing geographically. And so we're going to move from East Africa and go all the way to the middle of the US. And in fact, all over the US, as Chuck Daugherty has provided great support throughout the United States. Chuck, thank you so much for being here, and looking forward to what you have to contribute to this conversation. The floor is yours.
Thank you, Carlton. I appreciate being offered to speak today. This is just exciting for me. I'm pretty excited about it. I'm going to start with just some really basic information about ACT Missouri and myself, and let you know kind of where we're coming from. ACT Missouri has been around since 1991, originally just serving the single state of Missouri, providing all the training, consultation, technical assistance for substance use prevention for the state. We've done that since 1991. A couple of years ago, we got the ability to house the Mid-America PTTC, the Prevention Technology Transfer Center. And then we're serving regional. Same thing we did in Missouri. Now we're doing it regionally and doing some stuff nationally with that going on. One of the foundation that ACT Missouri has been built on since 1991 is we wanted to be the agency that served as the prevention catalyst to empower individuals and foster partnerships to promote healthy, drug-free communities. We've always been about communities. We've always believed that communities can solve community problems. Local folks can solve local problems. And we promote that across our area. We've recently decided and realized that the best way to build capacity in our area and in our region is through using community. We want to build a community to build capacity. And that community can be anyone that wants to get together. We've worked really hard on a professional community, on individual communities, on county community coalitions. But we know that to build a community, we can build capacity and make prevention better. Do a lot of stuff with collaboration, knowing that anytime we can do prevention is better together. We're really trying to break down silos, really trying to get everyone to work together, and we know that prevention is better together, and that together we are stronger and offer a bigger product for our communities and our folks that are working with us. We've been doing the same thing since '91, and it was going into communities, and we were training and would show up with our LCD projector and our PowerPoints and do our training, and we're pretty successful at it. Then the pandemic hit. Then we got COVID, and had to figure out ways that we could provide the services we want to provide and still serve our communities and build that capacity. And we were able to go online and start using online platforms, social media platforms, to get that stuff done. In the beginning, personally, I didn't think it would work. I wasn't sure that people would want to come into a Zoom meeting and spend 3 hours in a meeting, and I was wrong. It's been very successful. One of the things that we did is ACT Missouri is the state SAD, Students Against Destructive Decisions affiliate. We have the state SAD program, and it's for teenagers and high school age teenagers. And they took to the online platform like you would expect. They've been really successful. Our youth ambassadors working with SAD, our youth from across the state of Missouri, hopefully eventually from across the region, they get together and want to bring prevention services back to their schools, back to their communities. This year, our SAD students, youth ambassadors, got together online, met online, did everything themselves with the direction of our SAD coordinator, and published a comic book about anti-vaping ban. And it's an incredible comic book about the hazards of vaping. And it's built by kids, for kids. And again, just to support community people, local communities, solve local problems. They knew how to talk to kids in high school. They presented this comic book that is pretty slick, pretty classy, looks like a comic book, same kind of artwork we saw in the old comic books. And it's amazing how well they did and what kind of progress they're making with that and what kind of outcomes they're having. Additionally, our SAD coordinator has published on social media and on some learning platforms how to work with youth. It's a multi-series on how to work with youth that anyone can log into, anyone can read, anyone can learn from. Schools, teachers, coaches, parents. There's just ideas on how to work with adolescents. We've also increased our Facebook Live. We're doing Facebook Live a couple of times a week with different folks in the community talking about different problems that they might have, or just exposing folks to information they might need. We spent a couple of sessions on trauma with kids, being out of school, being homeschooled, missing their friends, missing their activities, and having to stay at home in quarantine. We've had people from across the community talk about services they provide, how to provide medical services, how to do telehealth, how to do all of that stuff just because we need to do it. Our Facebook Live sessions are about 10 minutes long. It's a brief interview, give the information out with some backup information and how to get more information. So we were doing that before, and it's been very, very successful with our folks on Facebook Live. We've increased our podcasts. PTT, Mid-America Prevention and Technology Transfer Center and ACT Missouri have put out 36 podcasts that talk about all different subjects in prevention, substance use misuse, substance use prevention by local and national and international presenters. Great information there. People are loving that. Lots of hits. Lots of people are downloading our podcast and subscribing to it. So we were able to get a lot of information out through podcasts that we weren't using before since the pandemic hit. One of the other things we've done that I think is really amazing is we're doing a lot of learning academies. The first learning academy we did was for drug endangered children. One of the things that ACT Missouri and the Mid-America Prevention and Technology Transfer Center really is interested in is providing services to drug endangered children. So we've worked with the National Alliance on Drug Endangered Children to put together a multi-series learning academy that was multi-session. It was piloted in Kansas, across the state of Kansas. We partnered with National DEC and talked about what it is, what drug endangered children are, what it means to be a drug endangered child, how to handle that. Plus, we also put in some information for the professionals running the groups on how to have those virtual conversations. do the virtual work that we need to do to get coalitions up and running and how to make the coalitions work. Some of the coalitions we worked with in Kansas already knew about the substance abuse prevention skills training, already knew about the strategic prevention framework. So they were able to incorporate that with the national deck stuff and the things we're doing to meet that population. Many of those groups in the learning academies and the DEC academies specifically use the Zoom platform, breakout rooms. It was just like going to a conference because we have the 3 or 4 different breakout rooms with different topics. Folks would come in, we talk about it, go back, process as a group. So some really good stuff that we were able to do with the pilot learning academy in Kansas for the drug endangered children. The most amazing thing about that was, the most successful thing is at the end of that academy, there were 6 brand new coalitions that really wanted to address the issue of drug endangered children. Just so that we increased that capacity, we increased the community's ability to meet the needs. And there's, I think, a couple more online that's coming in. I keep saying the chat and it confuses me, I'm sorry. It pops up and I'm trying to read it and talk. So that was some of the neat stuff we've done. We've also done a lot of other community practices, learning academies on other issues. We have come up with community of practices we're working with. We want to meet everyone's needs. So working with communities and have a community of practice for just community coalitions. We want coalitions to understand and be able to work together and across our region, be able to work with each other and understand their communities. And so we have a coalition community of practice that's a multi-session meeting, get together, talk about what's going on, there's a topic, and then they work on problems themselves, and it's a lot of self-learning. We have a community of practice for training and technical assistance providers. So they'll be able to get together and work together to work with their coalitions. And again, that's a multi-session training. They get some information, but a lot of their stuff is just between themselves, just be able to work on. And we have a behavioral health workforce community of practice that's the same setup, same thing, that we want people to work together across the state, across the region, and eventually across the nation. People do better when they're working with their friends, working with their communities, and understand each other. One of the success we've got from that is that we've got states actively collaborating to do trainings. That didn't happen before. States were pretty much bound by their boundaries, by their state lines. Now we've got people crossing those lines, work together because they understand that prevention is better together and that we can get a lot more accomplished if we're doing that.
Chuck, you have 2 minutes.
Okay. I guess the last thing that we're working on that I kind of want to share is pursuing some online interactive education that's kind of inspired by the program In Plain Sight, where you go into a child's room and see where they might be hiding drugs or what's available that parents may not know to look for. And also we're doing one inspired by Shattered Dreams for 15 minutes, where they have the car accident, fatality car accidents from someone that just made one bad mistake. So we've got a lot of stuff going on that we're moving to online, moving to social media platforms, and we're doing a lot more in the digital stuff, and it's being successful. We're making a difference across our service area, and I think I'm done. Thank you, Carlton.
Chuck, fantastic. Thank you so very, very much. A lot of information you provided. And according to all the conversation in the chat, a lot of folks were really looking forward to getting greater information, more information. We provided some of the links. Thank you for that, Dave. For those of you who are interested in some of what Chuck had to mention. And so I'm going to ask Anna to come back on camera if she wouldn't mind. But we have a question in the chat. I really appreciated the fact that Antonio was able to share a lot about the impacts of the pandemic through some of the research that he shared. Anna really spoke to how she and UDAL, the Uganda Youth Leadership Leadership Development organization, is really trying to meet the needs of their communities beyond what the government is actually offering, beyond just the advice of washing hands and face masks and social distancing, but understanding that if they're going to do prevention well, they have to meet those real needs of folks where they are. And how Chuck really talked a great deal about how they've had to adapt their practices by going virtual, utilizing things like podcasts and Facebook Live, and developing these learning academies. Extraordinary. One of the questions is that many of the programs and strategies that all three of the presenters discussed, such as social media, seem to address youth. How are we addressing the need for prevention to adult populations? And it's an interesting question. And so, but one that's really merits a response. While we understand that through most of our prevention work and our prevention efforts, we are focused on preventing young people from engaging into the problem behavior. And so therefore a great deal of our attention is towards young people. There is an opportunity and a need for us to look at the totality of our population and how we're addressing these needs. And so I will come first to Chuck to see if you have a response, or I'll ask any of the panelists, do you have a response to that? Who would like to answer that question?
I could start briefly.
Okay.
Much of what we do online is for professionals, for adults, to help prepare them to work with other adults in their community. That's kind of just the nature of our agency, is we want to train the other helpers and their caregivers to be able to meet the needs of folks. Some of that will be through their own online stuff that we're teaching how to meet virtually, how to have the conversations virtually, how to have tough conversations in a virtual setting. So while we're not addressing people directly, we're training to have other caregivers be able to do that.
Got it. Excellent. Anybody else want to add to that, Anna or Antonio?
Yes, Carlton, I can come in now. Why UDEL focuses on youth is because we believe that any work done with a young person will enable them turn into better adults. So as they're crossing over from young adulthood to adulthood, they're able to make informed decisions and not make the same mistakes like our parents made before, or like their parents are making. So we are starting to turn the turns from just having parents get information on prevention when they're already parents or when they're already adults, but let them get into that stage of adulthood with the sufficient information that they need and skills that can enable them. However, what we have seen in our program is that when it comes to the adults or to the parents or to the caregivers, we need to focus more on information and also ensuring that we bridge a gap between trust and care and understanding the mindset of a young person. So we've developed programs that are looking at prevention, smart parents, that we work closely with Mentor Foundation. I don't know if you've had a chance to meet Mentor Foundation, but they developed a very good prevention smart parents program, which we have implemented and adapted as Uganda Youth Development Link. And it has helped improve the communication between the parents and the adults. But also for the adults, I think at that stage, it's more of earning an income, having a survival, having a job, having a family. They're not looking at these other things that will, lead a young person get into addiction. So if we can mitigate the addiction before a young person turns into an adult, I think for me that would be the best prevention strategy that we need, than waiting for them to become adults and then start looking at prevention work. Thank you.
Thank you so much. And Antonio, please.
Yeah, it's a wonderful question, and we made us this question 1 year ago, more or less, because not only for COVID crisis, for COVID-19 crisis, we thought and we understand that what we were developing was very specific, and we need to understand the need of information of different stakeholders. So that's why when we are designing any kind of program, we are making a participative action strategy. So we join with different stakeholders, we connect with them, trying to understand what are the needs that they have got, and understanding that there are different levels of needs, because it's different, the needs that they may have. And also including young population when they have gone to develop, when we have to develop a prevention program, but also when we are talking and we are working with adult people, we join together with adult people, and we find, we hear what they need, but we hear what they need in a forum in which are all the rest of the stakeholders involved. Yeah. It's slower. This process, being honest, this process is slower. Sometimes we want a very fast and quick way to achieve the goal. If we use the process, the participative process, it's going to be slower, the process, but it's real that it's going to be much more productive than the traditional process. But it's a very, very interesting question. Very, very interesting.
Excellent, excellent, and thank you all for your responses. Giovanna also added in the chat, for those who may not have found it, that that she wanted to also add that UNODC will also be looking into the needs of senior populations, right, and asking and looking at anyone with experience and best practices and studies. Please to reach out to them. Thank you so much for Giovanna. We are right here at the break time. I want to thank our panelists for excellent presentations and being excellent resources for us all. And so in the best way possible, I will say muchísimas gracias. I will say and I will say thank you all very, very much. It's been an extraordinary presentation. We are going to go to a break right now and to step away from the computers a bit for just about 10 minutes and then come right back. And we're going to take this conversation to a new level. We talked about the practice on the ground with these folks. We're going to have extraordinary leaders come on next, who's really going to talk about the systems and the policy implications that their systems have to deal with as a result of this. Looking forward to that conversation. Thank you all so very much. Dave, I think you have a timer and some music for us to listen to.
Thank you very much.
Take a break, folks. We'll see you.
welcome back. I have to say the timer paired with the ballet music was a little stressful for me. It was giving me some flashbacks to my not so illustrious time in the ballet studio. But we're back, and I just want to say a quick thank you to our first panel for all that great information, and to Carlton for his skills in moderating and keeping us all on track. I hope I can do the same. For those of you that know me, you know that policy is my happy place, followed closely by research. Data and research determine the path we take in effective strategies in prevention, and policy impacts the daily decisions we make when it comes to our public health and our public safety. Think smoke-free zones, tobacco-free zones. Changing those policies really changes the way we have different behaviors with public health. So with that, let me introduce you to the three outstanding individuals who make up panel number 2. Like Carlton did, I will introduce all three now so I don't take up any of their time in presenting. So our first panelist is Laurie Krom. She is the director of the Collaborative to Advance Health Services at the University of Missouri, Kansas City. She is a leader in grant development and implementation, having received multiple multi-million-dollar federal awards. Under funding from SAMHSA, she is the principal investigator of the Addiction Technical Transfer Center, TTC, Network Coordinating Office, NCO, and the International TTC, NCO, the co-director of the Prevention TTC, NCO, and the ATTC, co-director of the Opioid Response Network. She has received funding from the President's Emergency Plan for AIDS Relief and the CDC to build capacity in HIV prevention in the United States and abroad. And her expertise is building and strengthening interorganizational networks to deepen the impact of public health collaboratives. Our second speaker is Kristina Sperkova. Kristina has a master's degree in psychology from the, I'm probably going to pronounce this wrong, Komines University in Slovakia. Kristina can count on 20 years worth of experience working in civil society in the field of health promotion with a special focus on prevention of harms caused by alcohol and other drugs, working on all levels of society. Kristina started her career in a local peer program in her hometown community. In 2014, she was elevated to international president of the global Movendi movement. She served as Secretary General of the European Youth Organization, where she successfully developed innovative and compelling programs, projects, and campaigns to empower young people and mobilize youth organizations to promote healthy lifestyles. In this work, she has earned merits in both raising funds for youth activities to promote health and well-being, as well as building a platform for political engagement of young Europeans in public health policy making. From 2012 onward, Kristina worked for a Swedish NGO, the IOGT-NTO movement, that conducts development aid work with partner NGOs in Southeast Asia, East Africa, and the Balkan countries in the field of official developmental assistance. She worked to build civil society capacity to tackle alcohol as an obstacle to development. Combining expertise from her master's degree in psychology with her know-how in community-based work and human rights-based development work, Kristina has dedicated special attention to addressing the needs of marginalized groups, such as women and children. As the international president of Movendi, Kristina has been representing on the highest levels the voice of more than 135 civil society organizations from communities in 56 countries worldwide. Under her leadership, Movendi International is developing innovative approaches to the prevention and treatment and rehabilitation of alcohol-related harm, advocating for the health and in a comprehensive approach to tackling the global burden caused by alcohol and other drugs. Our third panelist is Joanna Travis Roberts. Joanna is the Chief Executive of ISSUP, the International Society of Substance Use Professionals. As ISSUP's Chief Executive, Joanna ensures the effective running of the organization, taking responsibility for staff, work outputs, stakeholder communications, board and funder reporting, good governance, and adherence to statutory obligations. She has worked in the substance use disorder field since 2001 in a variety of capacities. Her educational background is around literature and languages with a postgraduate specialty in marketing. Her professional life has encompassed a wide range of responsibilities and research around communications, event management, and leadership. After graduating from the University of Leeds, Joanna began working as part of a research project managed by Mentor Foundation and UNODC, gathering evidence-based prevention and practice around the globe. This project developed into an online portal of prevention information, which Joanna was key in the development of from inception through launch. Building on this experience, Joanna has managed a number of information dissemination projects in the field of substance use prevention, including a frontrunner in online e-learning, Prevention Smart Parents, a course aimed to support parents and caregivers in their prevention efforts. From the international perspective, Joanna has consistently worked to engage as international audience in quality standards and evidence-based practice. Her personal mission has always been to use her communication and marketing skills and expertise to ensure organizations communicate effectively with their audience to make knowledge and resources as accessible and therefore as effective as possible. In this way, she is working hard to make ISSUP both accessible and effective for its wide range of users and members. Okay, let's start with our panel, and up first is Laurie.
Well, thank you very much, and thank you for inviting me here today, and welcome to everyone. I've been looking at the chat, and I noticed that a number of you, at least I think 4 or 5, are from the Hudson Valley area in New York, and so I want to say a special shout out because that's where I'm from originally. Let me see about sharing my screen here. Okay, I want to talk to you today about the International Technology Transfer Centers and the Prevention Technology Transfer Centers. So the Technology Transfer Centers, and I know that that's a little bit of a strange name. It sort of makes it sound like a telephone company, and since I'm wearing this beautiful telemarketer headset, it really adds to that. But actually, what we are, a group of organizations that share a purpose to develop and strengthen the specialized behavioral health and primary health care workforces that provide prevention, treatment, and recovery services for substance use disorders and mental illness. And we do that by helping people and organizations incorporate effective practices into their services. And you'll see here I'm focusing on the US-based technology transfer centers first. The US-based TTCs are funded by the Substance Abuse and Mental Health Services Administration and began with the Addiction Technology Transfer Center Network, which originally started in 1993 and has had decades of success in promoting the adoption and implementation of evidence-based treatment and recovery services. And then a couple of years ago, SAMHSA decided to expand the success they had with the ATTCs to fund 2 new technology transfer networks, the mental health TTCs and the prevention TTCs. And we've already heard mention of the prevention TTCs a couple of times on this call, during this conference, as my colleagues Dave Clausen and Chuck Daugherty from the Mid-America Prevention TTC Regional Center joined us today, and Carlton Hall is also a member, actually has worked throughout a number of the TTCs, prevention TTCs, but I think has a specific emphasis in the Southeast prevention TTC. So I just wanted to acknowledge my colleagues here today. I'm going to focus first on the ATTCs. The ATTCs, as I mentioned, have been around the longest time, and before they spawned the prevention and mental health TTCs in the U.S., the first expansion of the network came when the U.S. State Department, and specifically the President's Emergency Plan for AIDS Relief, took note of the success of the ATTCs domestically and decided that it would be a good idea to expand the program to certain countries across the globe that needed support or could use support in expanding their capacity to treat substance use disorders in order to control HIV. And so I've included here a slide with a brief history of the international ATTCs. As it says here, in 2005, we first partnered with Vietnam and opened a Vietnam International HIV ATTC in 2011. And then we expanded the international ATTCs in the years following into 8 other countries in Southeast Asia, including Thailand, Laos, Cambodia, Myanmar, Indonesia, etc. And then also in South Africa and in Ukraine. Unfortunately, or as it turns out, fortunately, because we are experts at turning lemons into lemonade, the President's Emergency Plan for AIDS Relief, that particular area of the U.S. State Department, decided to end the funding for the international HIV ATTCs. But because those international ATTCs had been making a real difference in the countries where they were located, another portion of the U.S. State Department, the International Narcotics Organization part of the State Department, you can see the logo here, decided to pick up the program and help us expand it to other countries and to really focus it more on substance use and the continuum of substance use from prevention, treatment, all the way to recovery. So while the international ATTCs had this specific mandate to focus on treatment and expanding treatment capacity, with the new funding from INL, we were able to transform and start a new program called the International Technology Transfer Center Network, and to really service across the spectrum from primary prevention to recovery, and then also look at the continuum of intervention and treatment. So we are in the process now of transitioning from these international ATTCs to the ITTCs. This has only been going on for a few months. Our first ITTCs have opened in Vietnam, South Africa, and Ukraine just in October of 2020. So very new. The ITTCs are designed to accelerate the diffusion of scientifically based practices. And in order to do that, ITTCs will serve, and I say will because they're so new, they're just getting their feet under them, but will serve as strategists, conveners, educators, and capacity builders. So there are many people who are doing training, workforce development in substance use prevention, treatment, and recovery. There are many groups who are looking at policy and how to help policymakers make scientifically based decisions around policy. There are many groups looking at international standards of prevention, others who are looking at creating products and services that can go directly out to the public. And the idea behind the ITTCs is that we'll take a big picture approach and really look at systems level. What are the needs? How do we put all those pieces together? Not how does the ITTC do everything, but how can we collaborate together in a specific country and then across the globe to leverage what is what is already going on, what is already being done, and have a deeper impact overall. The ITTCs will be and are a branch of the International Consortium of Universities for Drug Demand Reduction. ICUDDR is another program funded by the U.S. State Department, INL, and offers academic programming support and research development support to universities and research institutes across the globe. ITTCs, which are almost always, not 100%, but almost always located at universities and research institutes, made sense to align with ICUDDR and really launch and streamline services by becoming a branch of that organization. We will be expanding from our initial first 3 countries of Vietnam, South Africa, and Ukraine to Peru and Colombia next, and we are in conversations with about a half dozen other countries, including the United Arab Emirates, to launch ITTCs in the next 9 to 12 months. And we really believe that each individual ITTC is stronger together, and so we form a network, and I am the director of the coordinating office of the whole network, where we can share lessons learned, build on each other's strengths, and leverage resources. I want to invite you all to our launch for the International Technology Transfer Center Network. It's going to be February 24th. You can find out more about the launch and learn how to register on our Facebook page, which you can find at facebook.com/ITTC network. Now I want to move on and talk about how the International Technology Transfer Centers are connected to those other 3 networks that I started this presentation talking about, the US-based ATTCs, MHTTCs, and PTTCs. And in particular, I want to focus, given the audience here and the nature of our hosts, I want to focus on the Prevention Technology Transfer Centers. So the PTTC network, as has been alluded to a couple of times, is funded by the Substance Abuse and Mental Health Services Administration. And here you can see a map of where the different PTTCs are located. Those of you who are in the United States can find a PTTC regional center that covers a state near you. We also have 2 population-specific TTCs, one focused on Hispanic and Latino populations, and one focused on American Indian and Alaska Native populations. And I particularly want to mention the PTTC that is focused on Hispanic and Latino populations because they produce many resources, including live and recorded webinar events that are available in Spanish and in Portuguese. The purpose of the PTTCs, just like the purpose of the other TTCs we've talked about, is to deliver, to improve implementation and delivery of effective substance use prevention interventions. And we provide training and technical assistance services to those in the substance use prevention field. So how do we figure out what we should offer? How do we assess and identify needs? Each PTTC has an advisory board of stakeholders from their region. and also does other kinds of needs assessments through surveys, focus groups, informal communications. But really the job of each PTTC is to be the eyes and ears of their region or the population of focus, and relies heavily on their advisory board as well as conducting ongoing needs assessments to learn what's going on, where are the gaps, where are the hot spots, what do we need to identify, what do we need to focus on at this particular point in time. And so I thought I'd give an example, given that we're so focused, as we should be, on the pandemic right now, and the topic of this panel is really looking at how COVID-19 has affected prevention services. I just wanted to highlight an example from one of our regional PTTCs. This is the New England PTTCs. They, as many of us, recognized an immediate need to provide information, training, and resources to prevention professionals to meet the challenges faced in transitioning service delivery as a result of the pandemic. And so by March 23rd, which is just about a week and a half after in the US we went to stay-at-home orders, they already launched a survey to their constituent base about where they asked, what is it that you need? What are your challenges? What could be helpful? What are your biggest stress points? And so their region includes 6 states in the northeast part of the country: Maine, New Hampshire, Vermont, Massachusetts, Connecticut, Rhode Island. And they had 144 people respond in a short time period. So keep that in the back of your mind. Once we do those kinds of needs assessments and talk to key stakeholders, then we work on annual work plans. We develop goals and objectives. We get that approved by our funding agency. And then based on those goals and objectives, we conduct events, conferences. I think Chuck mentioned earlier learning communities. We do trainings. We have meetings where we bring together key stakeholders. We also develop products, toolkits, online courses, informational sheets, lots of kinds of products that can take science-based information and distill it into essential elements to make it accessible to the audience that we're hoping to reach. And then we post those products for free, and many of our events are open to the public and available for free through our website. And I will give you the URL for the PTTC Network website in just a moment. But I wanted to first go back to that New England PTTC example. So they did that survey immediately, or almost immediately, after we all went to stay-at-home orders for COVID. And they really did use those results, the information they got from that survey, to tailor what they were going to be doing in the upcoming months. So I just picked two things here. I know we're short on time, but I wanted to give you a flavor for how it is that we do this work. So a theme that came out of their survey is that prevention specialists in their region, one of the challenges that they were facing was dealing with a mental and emotional stress. And I'm sure we can all relate to that during this time. And so they were able to focus on that challenge and then provide a resource to help people to deal with that challenge already in May of 2020. And the webinar, for example, that I highlighted here was titled Navigating Difficult Times, Calming Anxiety and Building Resilience and Connection. Another example of a theme that came out of that survey was how to convert to an online platform. How actually do you take your prevention activities and convert them to an online platform? So an example of how they responded to that need was in July, they had an online training titled Virtual Facilitation for Caring, Connected, and Interactive Remote Meetings. as I promised, here is the PTTC Network website, pttcnetwork.org. And I know I'm running short on time. I just wanted to highlight one resource in particular that may be useful to those of you who are on the ground in the field. On the website, you can navigate if you right, actually there should be a banner right on the home page, but you can also click on the resources link. And we have developed in response to COVID a special themed page called Bringing Prevention Virtual. And this is just a screenshot of the page. It goes down and there are many resources listed and detailed on the page. Everything in blue there is a link and you could get to more information. So thank you again for inviting me, and I hope you take advantage of what is already available with the Prevention Technology Transfer Centers, and then look forward to what similar products and services the International Technology Transfer Centers will be developing and bringing to you in the near future. Thank you, Amy.
Thank you. Thank you for all those great resources and giving us the websites to access them all at. And we probably have some questions, but I'm going to save them toward the end of the panel. So we'll have, we are ready for Kristina next.
Yes, hello. Here I am. Thank you very much also from my side for inviting me and for organizing this. And I will jump directly to the topic. So I'm going to talk about Movendi International and what kind of impact COVID-19 had on our work and what challenges we faced. And I will hopefully share also some best practices with you. And this was actually the structure that I have described for you. And before I go to that, I understand that not everyone is familiar with Movendi International. So that's why just a few sentences about the organization. So we are a social global movement that works with development through substance use prevention, or maybe even be even more specific with development through alcohol prevention. And we are approaching prevention and the whole issue from a very comprehensive point of view, or with comprehensive approach. So these are the 6 strategic areas that we are working with. So on the basis of it is a social movement. As I said, that we are a global social movement. We are not a lobby organization or a small group of people who are interested in the topic and dealing with this, but we are bringing together civil societies, as also Amy introduced me in the beginning, from 56 different countries that are active in the communities. And not only that, no, we are not working only with our members, but of course with many partners, like-minded organizations and institutions. So for example, we work also together, closely together with World Federation Against Drugs, as an example. So that's the social movement. That's a very important part of our work. We don't think that we can actually achieve anything if we do not have people behind us. The main area of our work is advocacy work, both alcohol and other drugs, and that I will come then closer or deeper into it, and when I talk about the impacts as well. What we also are doing we are exposing the industry practices, so alcohol industry first and foremost, but also, for example, cannabis or marijuana industry. Another part of our work is changing the norm, so changing the alcohol norm, because everything that we've been talking about, the prevention, but also the problems with, for example, especially now, really bigger problems during COVID pandemic with recovery and treatment, are also hindered by the stigma around it, and also by the norm that has been created. So in the current alcohol norm, no one has actually an alcohol problem, just few individuals who have failed because of their own behavior or weaknesses, and like that's how it's presented. And that's why we also really need to work strongly with changing this alcohol norm. So then also people who are already having problems can access help better, and then also use or like utilize all the help that they receive from different treatment and recovery approaches and stay then on the safe side. And then another part of it is also the discourse. So we are looking into how all the community, scientific or academic community, politicians, but also civil society, how do we actually talk about alcohol and also other drugs? And aren't we sometimes part of the problem in the way how we present the problem? And this can go also back to what even Giovanna in the beginning was talking about, that prevention is presented as something that doesn't work, and sometimes because also we like the way how we talk about it, we are contributing actually to spreading wrong understanding of the concept of prevention. So that's what we are also working with, so that can change. And so when we have, as I said, or maybe Amy, we have 134 organizations in 56 different countries, and then they have been working with all these nice strategic areas that we have, and then and we had very nice plans for 2020 and on, and then COVID has come, and then we had to change and adjust. But the thing is that the COVID-19 actually just highlighted the issues that we have been dealing with also before. So alcohol has already been a problem. We have already been talking about alcohol epidemic, and now we could see that the people who were using alcohol had bigger problems, for example, in dealing with COVID or recovering from COVID. So we could understand already from the beginning of the pandemic, but there are more and more studies and more evidence that alcohol is really straining the immune system of human body, and then also dealing with COVID-19. At the same time, alcohol is one of the risk factors for non-communicable diseases that are a serious condition also in COVID-19. And again, we can see that people with NCD or non-communicable diseases condition have bigger problems in recovering from COVID. And I don't really know the group of the people who are listening, so very shortly about the non-communicable diseases, that those are then the diseases that are not infectious like COVID-19, but are spreading in a very simple way, presented by a lifestyle, but it's also a consequence of the social economic status and of the influence of the commercial determinants, like different industries like tobacco, alcohol, fast food industries, that are creating these conditions in people. And the conditions are like cancer, different lung diseases, obesity, cardiovascular diseases. And as I said, alcohol is one of the risk factors. The other risk factors are tobacco, lack of physical activity, and bad nutrition. So that was the alcohol and immune system. Then we also have alcohol and health system. So of course, alcohol and like different problems related to alcohol, be it violence, be it car accidents, different other injuries, or alcohol use problems, are also then straining the health system. And especially now when every person, every hand is really needed to deal with COVID, it's really a problem that could be prevented if we didn't have the alcohol problems, alcohol-related different problems and injuries that are just also then taking space in already exhausted health systems. So that we realized also very, very much in the beginning. And then also alcohol was alcohol sites and events are actually hotspots for spread of COVID-19. So that was the background that we have started working with from the beginning. And right in the beginning, already somewhere towards the end of March, we have issued statement of concern because, as I have also mentioned, that we are dealing also with the industry practices and exposing or revealing industry practices. And we, in the beginning, were really concerned about the position that alcohol industry was gaining in the pandemic, because the industry started producing the sanitizers, hand sanitizers, and started getting lots of free PR from governments who were taking pictures and praising the industry for all the help with the sanitizers they were providing. While we knew that while they were providing hand sanitizers, there were people who were like flooding hospitals with alcohol problems and or the non-communicable diseases and all these that I have described just earlier. So we were really concerned about that. Then we also saw from the beginning that the alcohol industry wanted to have preferential treatment. Then you might know that in some countries alcohol has been pronounced for essential product. So while everything was locked down and people could really buy only some groceries, alcohol was still available. While we knew that alcohol was increasing also now the violence, as Anna was talking about, in the communities or in the households now, when all the families were locked in one house or apartment, this was on the rise. But alcohol was still in some countries then announced as an essential product. And then also, of course, the industry was also asking for different deregulations. So we know what is working to reduce alcohol-related harm, and that's the three when it comes to policies, and that's the so-called 3 best buys. So it's limited availability, marketing, and also increased prices through, for example, taxation. And some countries have it already implemented. Some countries have been working on these measures to introduce them. And now with COVID, it stalled also on the request of the industry, as they were providing help, for example, with the alcohol or hand sanitizers. They also demanded some kind of closed eye, or at least one eye, from the governments when it came to implementation of these policies. So that was also that was what we had to deal with from the very beginning. So what we had to do was to coordinate our members, really to, like when the first shock came, just to shake and realize what's going on, to get really fast overview what's going on in different countries, and gather our members to compare and share experience between them, and start also helping with composing some kind of answers and demands towards the politicians, or like just showing that we are seeing this, even though we understand that COVID-19 then was almost like the only thing that the governments were dealing with. But at the same time, we had to show that we need to hold the governments accountable, and they cannot forget these issues, and they have to protect the policies they have, or even if possible, actually introduce the policies, because they would dramatically reduce the strain on the health system, for example. There were several countries or many countries that, of course, now are losing lots of money, and the economies are weaker. And for example, alcohol taxation is a solution that can provide support then to the governments to start implementing prevention measures, supporting the entrepreneurs, and all that, whatever they actually choose to use it for. So this is what we've been then dealing with. These are the measures that I have described, and that we have been that we had to look at during this pandemic. Availability in some countries got also naturally limited. In the countries where there were lockdowns, people couldn't go out, restaurants closed. So this was also a part of the discussion. Will the people now, when not sitting in the bars and restaurants, will they consume less alcohol? On what we could see, it went both directions. So some people really quit or reduce their use because there was no social pressure, there were no social situations to do that. But on the other hand, many people were also dealing with the problem, with the anxiety and depression caused by COVID-19 situation, and started using even more alcohol. I think when it comes to the US, the additional deaths of despair. So these are all the suicides and liver cirrhosis, for example, caused by alcohol during COVID. In the worst case, they would add with 150,000 deaths, and in the best case, with 27,000 deaths of despair. So the availability was, in a way, the situation was helping and not helping, depending on in which country we were, because as I said, in many countries, alcohol was an essential product, so it was still easily available. Then when it comes to marketing, the industry is incredibly creative. You know that, you for sure know it also from the marijuana industry. So there we had to really again point government's attention to what was going on, because it was really going over any ethical standards. Like when alcohol was presented as air that we need to breathe during the COVID, then we felt like this is really going too far, as we know that COVID is actually impacting lungs and people have difficulties to breathe, and then someone can come and market their product as something as needed as air. And then it comes to taxation, as I have already mentioned, that actually through taxations, countries could actually generate some income for the work that they need, and to support to health systems or to entrepreneurs or whatever, because all the parts of societies are actually really missing out. And when it comes to brief interventions and support, this has also been mentioned that this was actually closed down in many countries, so people who needed help couldn't. So, and that's very funny, because at one part alcohol was an essential product, so those people who had alcohol problems would easily access it and could consume it, but there was no, for example, access to treatment. So, and what we have been doing then also, like on the global level, we have also really, we were working also with the discourse, and also we were analyzing how, for example, WHO, World Health Organization, is talking about alcohol in this situation. In the beginning, we were really unhappy how the communication from World Health Organizations went, because it was very indifferent, like it was not really clear what the position on alcohol is. But then World Health Organization regional office in Europe has created a very clear fact sheets, and that was under the pressure that our member organizations and we have also created. So then the communication about alcohol, that actually it shouldn't be really consumed during this pandemic because it's making it all worse, has come out, and several other regions of WHO, I know PAHO for sure, have also signed under this fact sheet. And then we have also, we were following and we were analyzing different countries and the policies they are implementing. Some of them, as I said, were closing down restaurants and limiting access to alcohol, limiting alcohol sales. So we could, this analysis we could have, we have it also on our webpage, but we could have also, we could share it with other governments, and the governments could then be inspired by what they could do. And then, of course, we also turned inwards and we had to support our member organizations. So we created more online platforms. We had many more webinars and trainings. Here we have created actually a smartphone application for learning more about alcohol issues. We have more newsletters than we used to. And then we have created podcasts. I heard also in the previous, some other speaker was talking about podcasts. And like, so we went into the online or the virtual world. And here you can see, like in 8 months or something like that, we have produced more than 400 news stories and 230 scientific articles and blog posts, and then community solutions. And then I understand that I am also reaching the time limit, so I will skip this. And then I will just go also, as we are a global movement, so what I have told you that was happening on the global level, but then of course, also UDEL is one of the members in Movendi International, and so similar work was actually going on around in the country. And these are the categories of the work in a very simplified way. So there were many organizations that were really informing communities about COVID as such and hygiene. Then there were many who were creating support to caregivers. So like, for example, Listen First has been spread in the communities. And then the health promotion in general, as I mentioned, how COVID and alcohol are actually connected. Some were providing community kitchens and still working in those communities, so who were not able to be in the virtual world. Different helplines were provided for, and support groups. Kids were receiving some small packages, not virtual packages, but real packages. For example, in Sweden, with different games, so they could play them during for example, now during holidays, when still being at home and not able to go and to meet anyone. And then, of course, our members were doing the advocacy. So what I was talking about on the global level, they had to do, of course, on the national level, as there were many trials from the industry part to circumvent the laws that are existing or really weaken them. And so this also had to happen. And I'm really looking forward for more questions. And thank you very much for this space.
Thank you, Kristina. Thank you so much. So many things that you touched upon, and thank you for the great work that Movendi is doing, especially in the area of being, I guess if you would call it, a watchdog on really what the industry is doing. There's not a lot of organizations that do that kind of work, and that's, for the rest of us out there, bringing that to our attention is really important so that we can help follow your lead on the different advocacy efforts. And especially when you were talking about the different ways that countries looked at essential businesses, and here in the US, alcohol was an essential business, and as was the marijuana industry. So it was really shocking to see something that we knew was happening, but very blatant at a time when we were so focused on physical health, that these would be the places that were deemed essential. It was actually very sad. So we probably will have some questions, but we will go to our third speaker now on the panel, Joanna, and I see she's got her slides up and ready to go.
Can you just confirm it's the big slide you can see, not the presenter view?
I see I can see the notes slide.
Oh,
The presenter.
The next slide. Yeah, there we go. Perfect.
Thank you very much. Okay. Hi, everybody, and thank you ever so much for letting ISSUP be part of this, your sort of morning of activities, and have this chance to talk to you about our organisation. We are a global NGO, we're a membership organisation, and we really support the development of a professional workforce in this field. We really want to promote evidence-based and high-quality practice, policy and research across all three sort of fields of prevention, treatment and recovery. And we act as that central point to bring people together from all of those different levels within this very broad workforce. As an organisation, we evolved from a group of meeting of people who had this same idea that we want some coherence and collaboration across the field and around the world. We are funded by the US State Department's Bureau of International Narcotics and Law Enforcement Affairs. And we still work with all of the logos and organisations that you can see on the screen there. So just to give you sort of a snapshot of where we ended last year, which for all of us was a really pivotal year in terms of how we deliver our work and how we sort of go about our day-to-day practices. So we ended with 24 national chapters with over 17,000 members in 187 countries and territories, and online events that were attended 19,500 times. So we were really pleased with how last year went, despite the difficulties that everybody has been facing. Just to summarise, our vision is to create a connected, trained, knowledgeable and effective international network of substance use prevention, treatment and recovery professionals who are, as I said, undertaking, promoting high quality, evidence-based and ethical activities. And like I said before, we include research, policy making and practice within that. Now, in our mission to put the workforce on the map, one of the things that I always make sure that we make clear is that we see the importance of this field working together as a whole, and to recognise the contributions of all parts of the picture, you know, all corners that are working with us. So we include volunteers, family members, support workers, researchers, education professionals, law enforcement professionals, social work, education, medical. You know, we really do want to bring the full range of people that are working, and the list goes on. I'm sure I've missed out mentioning some area, but I'm just trying to get the point across that we are inclusive, and we want to everyone to recognise the parts that everybody plays in drug demand reduction. And on that same theme, we do see it as important to make those connections so that research informs policy and practice, so that practice informs research and policy, and so that we all recognise, as Kristina was talking about, that the impact of some of the policies upon all of these areas. So by having this broad net, if you like, if this large network of people out there all working together, we really hope to encourage this collaboration, this interaction between the different levels within the workforce. One particular close collaboration that we work with and really supports our members is the work that we do with the International Consortium of Universities for Drug Demand Reduction and the Global Centre for Credentialing and Certification. So with these two organisations, we endorse and support further education within this field by helping people to access the work that ICU DDR are doing, ensure that their universities have joined that network, and that our individual members might be, you know, accessing then those universities to continue their studies. And with the GCCC, we want to help the workforce get the recognition for the work that they are doing and the knowledge and experience that they actually have. As well as these two key organisations, we work with partners that are delivering the universal curriculum. So we work with Colombo Plan, the Organisation of American States, and UNODC, and with Healthy Knowledge, who are a platform giving a training across the board for this field, and we sort of help people engage with that training and go through to there. So for individuals on the ground, there's a lot of resources within our knowledge base that people can access, and they're not just ours. You know, we really do try to signpost people to the relevant places where they can get key information. Going back to our membership model, we have 4 levels of membership. So to join ISSUP is totally free, and there we have these groupings of a student membership, regular membership, which are those that are interested or sort of volunteering or starting out in their career, or professional membership to really bring in those workforces that do not necessarily see themselves as drug demand reduction professionals, but are significantly contributing. And then the last membership group is those who are working with specific qualifications, experience, and job roles within this field. So how do we do all of this? You know, now I've talked to you about a little bit about who we are. How do we actually do this? So we deliver our mission through 3 channels. We have a digital offering, which includes our website, our social media, newsletter, etc. Our events, which have in the past been in-person events and are now online events, and our national chapters, which allow us to operate on a country level. And I'll talk about all 3 in a little bit more detail. So the website was already a very key platform for ISSUP. It's where we talk about who we are. It's where we can bring everybody together from around the world, and where we can have this real centre, this hub of all of the information, all of the resources, all of the tools, all of the signposting to the key places for our members and for people that are interested in the field. It's available in English, Arabic, French, Spanish, and Portuguese, and that is an ongoing process of translation. We have a knowledge share, which is where we post relevant pieces of information, research, news, etc. for people to read, but also so can our ISSUP members. So people can talk about the things the knowledge that is coming out of their workplace, their country, their field, etc. We have networks, which is where people can discuss things online. They can enter into their sort of small little groups, or they can be larger groups where they can share information and ask questions, etc., and really just talk to each other in an online format. And it's worth noting that we have specific networks for those that are interested in the impact that COVID-19 has had on this field. And within our knowledge share, that's a specific theme as well. So we've sort of collated things that really apply to undertaking, delivering your practice, research, or whatever your day-to-day role is under these current conditions, and how we can support that, all of our workforce doing that. There are professional development pointers and places to go to how to enhance your career, events and webinars. So there's a calendar of all the things that are happening associated with the field. We have online events which are taking place, which I'll talk about a little bit later. Information on our national chapters and your own dashboard. So once you've joined, you can see everything that relates to your ISSUP membership. And as I said, we are very fortunate that this was already our key platform to talk to the world. So when the lockdown happened last year, we could enhance this and leverage this as a tool that people could use. And we did see our numbers, our membership numbers and our website usage and our engagement with people really increase. And that was excellent to see that the resources that we're providing are useful. We then really focused on that. So we had 3,368 new items added to our knowledge share last year. There were 1,038 events posted on the calendar for people to see what was happening on, and 1,516 network posts. So that's people talking to each other. When we realised, how much more we could leverage this online platform, we undertook a user survey last summer and have been sort of working through the findings from those and enhancing the things that people said, yes, this is working for us, keep doing it, or do it more, or do it like this, when we've been responding to that feedback that we had from our ISSUP members. If you want to go and visit the website, this picture here with the hexagons is our homepage, so you can see the COVID-19 support network. You can be directed straight to that, or go to the sort of darker red hexagon, which is the knowledge sharing. Again, you can investigate the things that other people have posted around this theme. So as well as our website, we also are online via our newsletter, which goes out every other week, which summarises key things from the website which are of use to people. We have social media accounts and our online events. Now, I talked a little bit about national chapters, and these, we partner with organisations or existing networks in the country and deliver our mission on a country basis. And again, they have been extremely key during the times that we have all been working within the COVID-19 restrictions, because each country has been faced with their own lockdown or their own circumstances and country-specific challenges. And our national chapters have been able to respond to those, feedback to us, but also undertake activities which are relevant and key for the workforce in their countries. We currently have 24 established national chapters, and others are in process. They undertake a range of activities, and you can see some pictures here, but again, it's very tailored to what the country needs. So we have online events, webinars, trainings that have been happening, focused newsletters, knowledge updates. One of our national chapters does a regular knowledge, sort of latest findings every other month. And they leverage our platform. So they use the things that are there on the ISSUP website and add to those to really make sure that they support their country, but also that we learn. We extract things from the country level so that it can be then used by others around the world. So the ISSUP event was always an annual event that took place in person, and until last year, where we held our first virtual conference. And we are still planning our next one to be in Abu Dhabi in 2022, and that will be a mix. So we are looking forward to going back to face-to-face meetings, but we're very, very keen to not lose the learning that we have all had from going online, because our reach was significant in terms of holding our conference online instead of in person, and we had other groups that we were perhaps more accessible to. So we hope to blend those two approaches going forward. And you can see here, this was where we took our event online last year in partnership with ISSUP South Africa, who coordinated that, and you can see the key organisation logos that we worked with. And that event really did have a huge impact for our participants, but for us as well, to see and learn what works, how we can be accessible to a greater number of people. As well as the larger conference, we have held a series of online smaller events, webinars and presentations or online meetings, which have included across this was over last year, over 19,000 participants in multiple languages, mostly on our platform, our sort of webinar platform, but also people using social media or different ways of talking to people virtually. And the wonderful thing about it is that they've been hosted by us or by our national chapters. We've had fantastic contributions from excellent organisations, and we've been so grateful for how many people have been willing to volunteer their time to contribute to these online events. But every time something like this happens, the reach, the way that it goes outside of geographical borders or even specialisms in workforce has been really quite eye-opening. So we're very grateful to the contributions, but also the opportunities that these types of online events have given us. And we started out the year thinking we'll do around one webinar a month, and now we do around 3 a week. So the response to that need has been, we were able to do that quickly, and we've learned a lot from it as well. So please keep in touch with us, ensure that you and your networks of people join the organisation, follow us on social media, and we're always willing to hear your suggestions, your contributions to really keep feeding this workforce and supporting the organisation.
Thank you, Joanna. Thank you so much. I'll just quick tell my personal story here. I had not heard of ISSUP about 3 years ago. And when I found out about it, I was amazed at all of the different resources and just the conferences and different things that you were doing. And it would have been so simple to put life on hold in 2020 and just say, oh, well, we'll wait until we can see each other in person. And ISSUP is probably the best example I've seen on how they have not only thrived through the virtual platforms, but have actually increased everything. So it is really phenomenal to see the work that you guys have continued to do. It's very inspiring. And for people who are not a member of ISSUP, you can join, it's for free. And I really would suggest looking at the specific groups that she talked about, the networking groups. You can go on there and have some great peer-to-peer conversations and communications and find ways to collaborate with others that are doing the same work you're doing. And it really is an uplifting spot, because sometimes we feel that we're doing this alone, and being part of that network really shows us that there are so many of us working together and making things better. So it's perfect. So let me look and see if we have any questions for our panel before I turn it over to Carlton for to introduce our closing keynote. It looks like we do have a question in the Q&A for Kristina. Kristina, what was the most effective response method to the alcohol industry?
Thank you for the question. That is very interesting. So the good response was from communities, because, for example, alcohol industry try to go around laws through in the countries where alcohol is actually sold only on specific places. So, for example, in Sweden, they wanted to do home delivery, and that is actually not allowed. But they wanted to do it with food as restaurants could deliver. So there, the communities really had to mobilize, and they had to really lobby or point at the problem to the local governments, and they have done so. And that is still actually being discussed. It has not been completely resolved, depending on which governments you have in different communities. But I think that the community mobilization was really helpful. Otherwise, it would just go through without anyone really just even lifting their eyebrow. So yes.
Okay, perfect. I don't see any other questions in the queue, but we will keep that open. And then also, you know, if as you digest all this information, if you're anything like I am, I will think of questions probably at 3 o'clock in the morning. Feel free to email those to me or to Carlton. I'll make sure we put our emails in there, and we'll make sure we get them to the appropriate person and get some answers for you. So I will now turn it over to Carlton, who will introduce our closing keynote.
Absolutely, and a round of applause for the last panel as well. Fantastic information. Thank you all so very, very much. I have the privilege of introducing a hero of mine. For 50 years, Dr. Robert L. DuPont has been a leader in drug abuse prevention and treatment. He was the first director of the U.S. National Institute on Drug Abuse from 1973 to 1978, and the second the second White House drug chief, forgive me, and from 1973 to 1977. And before that, he was the director of community services for the District of Columbia Department of Corrections. And from 70 to 73, he served as the administrator of the District of Columbia's Narcotics Treatment Administration. In 1978, he became the founding president of the Institute for Behavior and Health Incorporated, a nonprofit research and policy organization that identifies and promotes powerful new ideas to reduce drug use and addiction. A graduate of Emory University, Dr. DuPont received his MD degree in 1963 from the Harvard Medical School. He completed his psychiatric training at Harvard and the National Institutes of Health in Bethesda, Maryland. Dr. DuPont maintains an active practice of psychiatry, specializing in addiction and the anxiety disorders, and has been clinical professor of psychiatry at the Georgetown University School of Medicine since 1980. Forgive me, Dr. DuPont, I know you didn't want me to go through all of that, but I think it was well deserving to go through it. He is the author of Chemical Slavery, Understanding Addiction and Stopping the Drug Epidemic, published just in 2018. And I will say to everyone that that is a must read for everyone in prevention, treatment, and recovery. It is an extraordinary work. Within that book, should you read it, you will find an incredible story of Dr. Martin Luther King writing a letter for Dr. DuPont. Maybe he might share a little bit about that story during his presentation. As I mentioned, he is not only a hero to me, but he is a champion for our country in the US and around the world. Dr. DuPont, thank you so much for joining us, and we look forward to hearing about an incredible idea, One Choice, which has really galvanized the way we look at things here in the US. Take it away, Dr. DuPont. You're on mute, sir. You're on mute, sir. You have to unmute yourself.
Okay, now I'm unmuted.
There you go.
Now I share screen. All right.
Perfect.
I got to do this one too. Slideshow. Now, do I have to something about the share computer sound? Where is
Right.
that?
Dave, could you help him out?
Yes, sir. So you want to stop sharing your screen real quick?
How do I do that?
All right, it'll be at the top of your screen.
Oh, yes. Stop. Oh, no, I lost mine.
Yeah,
Yep.
that's good.
You're good. Now at the bottom of your screen where you clicked share screen, click that, and when the window pops up, select the screen that you would like to share, and then in the bottom left-hand corner, there are 2 boxes to check for sharing your computer audio.
Share computer sound. Yeah. And now I click the slides, right?
There should also be another one for video, optimize for video.
Optimize screen share for video clip, right? There it is. Okay.
Correct. Both of those. And then, yep, you'll want to share the entire screen so the videos will play.
So is that, I'm not sure. I think I've got the slides over at the side. Is that, how did they get that on there?
You'll want to go to presenter view.
Presenter view.
So that was the little button at the bottom that you're getting ready to click the first time you, yep, there you go. All right, in action.
We're good to go. Well, thank you very much. I have just been thrilled with this presentation and so proud to be with all of you. It's been a terrific experience for me. I want to pick up on just something Kristina said, where she was talking about alcohol, and give you a couple of numbers that aren't in my slides, but were stimulated by her. If you look at the United States, about all substance use disorders, in other words, all Americans, it's a little more than 20 million Americans who have a substance use disorder. 57% of them, 57% of all SUDs in this country are alcohol. The second number I want to give you, if you look at the illegal drug SUDs in the country, 49% of those are marijuana. When we talk about drugs, we often don't talk about those two, and why they're so dominant is because they're legal, at least in much of the country. Marijuana is by now. We get off into other things, but I always want to emphasize why she's doing that. And people want to have drug policy to have it be like alcohol. They don't think about the alcohol approach to drug policy has created this incredible problem that we have. So I just want to start with that. So here's what I'm talking about today. I'm going to have to be quick with some of these because I have a hard ending at the hour to end. So I'm under a little bit of time pressure here. As Carlin says, we're going to talk about one choice for health, a new way to think about prevention. Okay, we're in a global epidemic, a drug epidemic. There's an epidemic that existed before COVID-19, and it will be around after COVID-19, and that is the modern global drug epidemic. There's no hope of a vaccine for this disorder. Legal and illegal profit-driven industries, and again, Kristina pointed out this, are fueling the epidemic. They are busily providing the drugs and making it easier and normalizing the use of the drugs. What is the future of this drug epidemic? It is more and more drugs at higher potency with new delivery systems. The drug problem everywhere in the world is changing rapidly to more drugs, especially synthetic drugs, at higher potency with new deliveries. And this is going on in the context of a global movement to normalize drug use. But to reduce this threat, the issue is prevention. And we're going to go through that here today. We're going to talk about prevention. What are we preventing? It's very important to understand that the adolescent brain does not mature until the age of 25. And the adolescent brain is uniquely vulnerable to addiction. And that is very important in understanding what our problem is. It has to do with the brain and the brain function, that adolescent brains are uniquely affected by this. 9 out of 10 adults in the United States with a substance use problem began their use of that substance before the age of 18. And the earlier the use, the more likely the person was to develop later problems. So we're talking about a pediatric onset, a youth onset disease, largely. What is the goal of prevention? What are we trying to prevent? What do we mean by a drug? What does drug-free mean? Are we preventing use, misuse, overdose? And what do you mean by youth? Most prevention efforts in the world do not clearly specify what they mean on any of those variables, what they are preventing. And what we're going to talk about here is a way to be very clear. And it is based on science. It is based on data. And there's some very good news in it that people don't know about. And that better vision, that one choice as we call it, is that no use of any alcohol, any nicotine, because you've got to get nicotine into this discussion, marijuana or other drugs for reasons of health by use under the age of 21. Now, in much of the world, the legal age is 18, and just bracket that 21 and you think about 18 for some countries. But all the countries have a legal age. And drug use under that legal age, in the US that's 21, in other countries it may be 18, under that age, all use of nicotine, alcohol, marijuana, other drugs is illegal. So what I'm talking about now is refocusing all prevention messages and all programs on the goal of this health standard. That's what this presentation is about in its new concept. The ideas here is that this is a universal support of a clear message. Think about the message, always use a seatbelt. Do we think everybody always wears a seatbelt? We know people do not use seatbelts, some people don't. But every single person knows the health thing to do, the health goal is no use. How about wearing a bicycle helmet? Yes, people ride bicycles without helmets, but everybody who rides a bicycle knows that it is unhealthy and that the healthy choice is to wear a helmet. And the same thing is true about avoiding cigarette drinks and healthy diet and regular exercise. My point here is not that we're saying when we have a health standard that everybody's going to do it, but we have a health standard that says this is the healthy thing to do. This is the goal. And we don't have that clearly about drugs because we normalize the drug use. And that is a problem. Okay, now I mentioned about what is a drug, and there's a lot of confusion in youth prevention about some of the prevention is about drunk driving or binge drinking or cigarettes or vaping. It's endless, the number of specific things people talk about without thinking about the fact that it's all one problem, and that is youth use of chemicals. And all teens, all substance use is one threat. That is the basic concept that I'm talking about here. Our organization, Carlton mentioned, the Institute for Behavior and Health, analyzed the way the nation keeps track of drug use in the United States. We looked at the national survey, 17,000 youths aged 12 to 17, and we did a new analysis of it to looking at what is the relationship between the one use of one drug and another use. Is the use of one substance by adolescents associated with increased risk of using other substances, regardless of sequence? We're not talking about a gateway drug. We're going to talk about 3 drugs that are the entry for most young people into this. Now, this slide is a little confusing at first, so take a deep breath. On the left, we show Americans 12 to 17 who had not used any marijuana in the past month. And on the right, have used any marijuana, even one use of marijuana in about a month. And then we looked at what was the risk of their using alcohol. For the people who had not used, the youth who had not used any marijuana, the likelihood of using any alcohol was 8%. If they had used any marijuana, it rose to 44.6%. That's in, and then we see, here we go. That's 5.6 times more likely just on the basis of whether they used marijuana in that previous month. Okay. Then we look at binge alcohol use. 3.5% if no marijuana use. 27.5%, 7.9 times more if they had used any marijuana. And then heavy drinking, which is repeated binge drinking, 0.4% up to nearly 6%, 15.8 times more likely. And how about this? To look at the issue of cigarette use, 2.7% if they didn't use marijuana, 23.6% if they did use. And then other illegal drugs, 9.9 times. The point of this slide is that if they used marijuana, they were far more likely to use cigarettes, to use alcohol, and use other illegal drugs. Okay, let's look at alcohol. The slide's a little different format, but it's the same point. On the left is no past month use of alcohol. And you'll see there the likelihood that people who did not use alcohol using marijuana in this age 12 to 17 was 3.5%. Okay. Now you'll see that the likelihood of their using some alcohol use went up to 20%, and so on across the binge drinking and heavy drinking. It went 20, 34, 54. Only difference between that and the 3.5% is did they use any alcohol in the last month? So their marijuana use went from 20% more likely to use, binge drinking 9.9 times more, and heavy use 15 times more. Now, we look at the association higher with the use of other drugs. You'll see here more likely to use cigarettes in that too. The point of all this is that when a young person uses alcohol and when they use marijuana, they are far more likely to use other drugs than the people who didn't. And here's the same data for cigarettes. And you'll see no cigarette use in the last month. The likelihood of drinking in that month is 9.5%. And if they did use a cigarette, it's 4.2 times more likely that they use alcohol. It's 6.1 times more likely that they binge drink. It's 10.4 times more likely that they report heavy alcohol use. 7.7 times more likely that they'd use marijuana, and 7.7 times more likely to use other illegal drugs. Here's the point I'm making. All three of these are gateway drugs, not one or the other. But if a young person uses any of these substances, they are very much more likely to use all of the others. That's the key concept here. The crucial decision for health for youth is whether to use drugs or not to use drugs. That is the crucial one choice. And it underscores the clear need for a goal of youth prevention that is easily understood. But, you say, is that realistic? If people normalize youth using drugs, do experiment youth are going to try them for themselves. What would you think if somebody said youth should try for themselves whether they need to wear a seatbelt when they're driving? What do you think they'd find when they tried for themselves to learn? They'd find they didn't need a seatbelt, and they'd find their friends didn't need a seatbelt. That's a stupid way to think about it. That's the same thing with drugs. When young people use drugs, mostly they don't have any problem, and their friends don't have any problem. So they think there isn't any problem. But the question is it realistic to have this one choice? Now here's data that most of you have not seen that is very dramatic. And this is new data that we did at the Institute for Behavior and Health. It was never seen before, although the data has been there for 40 years. It was never looked at this way. We asked the question, look at the blue line at the bottom. This is lifetime non-use. This means what percentage of American high school seniors between 1976 and 2019 had never in their lifetimes used any alcohol, any marijuana, any cigarettes, or any other drug. In 1983, it was 3%. 97% had used drugs in their lifetimes. By 2019, it was 31%. That is an amazing growth. That means that nearly a third of American high school seniors and never in their lifetimes had used any drug today. Think about that. And then we look at the past month use. What was the likelihood of use in the past month? And of course, it was a smaller number than the lifetime use, and it was about 16% in 1983. Now it's 59%. Hey folks, that means 59% of high school seniors have not used any drug at all in the prior month. And look at that trend line and the steadiness of that over that time. Here you see the same thing for the 8th and the 10th graders. So you see that this trend is very clear, very strong, and you see that as they age, they use more. I mean, there's more use. That's easy to understand as they go through high school. But that trend line is very, very important, and it's been widely overlooked. People haven't thought very much about it. Here's about vaping. One of the things we did, we looked at vaping. And it turns out that, as you see from this, if this has used any substance in their lifetime, if an 8th grader had used any substance, had vaped, they had the likelihood that 80% of them had used another drug. If they had not vaped, it was 20%. Look at that, 4 times as much. If they vaped, they were likely to use other drugs. If they didn't vape, they weren't likely to use the other drugs, and much less likely. And then the same thing is true for the 10th and 12th grades. In other words, the vaping did not change the rates of people who had not used, because most of the vapors, especially by the 12th grade, were using other drugs also. It wasn't that they were vaping instead of using other drugs, they just added the vaping to that. And that's a very important concept to understand about what's going on. I'm going to quickly look at this one because this is a little complicated, but it really is important. Take a look at the alcohol at the top. This is past month use of alcohol by high school seniors, 76 to 2019. In 1978, it was more than 70% had used alcohol in the past month. Today, it's less than 30%. I don't think many presenters have told you that in the United States, there has been a dramatic reduction in the percentage of youth who are drinking alcohol. There's the evidence. This is how the country manages. And I'm very proud to say that this is from the Monitoring the Future study. When I was the White House drug czar, as Carlton mentioned that, I started this program. And it's a really important data. Now look at the cigarette number. This is cigarettes. It was about 40% in 1978. 40% of high school seniors were smoking cigarettes. Now it's less than 10%. And look at marijuana. You see that peaked also at the same time, much lower now than it was then. But it's come up since a low point because of the marijuana legalization movement. And you'll notice that marijuana crossed cigarettes in about 2008, and it's on track to cross alcohol in about 3 or 4 more years because of those trend lines and the way they're going there. Okay, here's what I'm talking about. One choice. I don't care about the word. I like the word. It's a great word, but it's a concept that I'm after. No use of any alcohol, nicotine, marijuana, or other drugs for reasons of health by youth under the age of 21. That's simple, clear, comprehensive, and realistic. This is a movement from youth, not from somebody else. They are changing and have been changing steadily for 4 decades. Our job is not to create a trend. Our job is to promote a trend that's coming from the youth. Now, what are we doing about this? How are we putting this thing together? We have started what we call a one choice community, and I'm inviting you. You'll see down at the bottom here. Our website is onechoiceprevention.org. Real simple. Onechoiceprevention.org. Okay. So we have a one choice community. We want to recruit you to get involved with this. There's no money. The idea is for everybody. You just join in the campaign to promote the trend that's going on. And I showed you the data for U.S. Other countries around the world, especially most countries other than Western Europe, have higher rates of youth who are not using. In your country, wherever you are, most of your young people are not using. What we really need to do is emphasize the importance of that decision and to give those youth who have made that choice the microphone, to let them talk to other youth and tell it informally and in big presentations about why they made that choice and how it's working out for them. We want to build on what we already have, which is a large population of youth who are not using. Parents, the first presentation was very moving about the importance of parents. Parents, I can't emphasize enough how important parents are. Parents need to know this is a realistic goal for their kids. They don't know that because the parents in the United States were in school when everybody's using. Everybody's not using now. And the parents are key. They need to know that their job as parents is to help their kids grow up drug-free. That's important, and it's realistic to do that. That's very important. Also, I think the student-created or youth-created public service announcements are really important to make this go. And you know, when we're talking about who's important, we're talking about parents are important, but not just parents, educators are important. The healthcare people, pediatricians in this country, the American Pediatric Association has made it clear that the health standard in this country is no use of any drug. We got to get all the pediatricians on board. The adults who work with kids have to be clear about this. And adults in our United States are not clear about it. They normalize the use too much of the youth. And I think it's really important to have them see this and understand this. And we need community-wide education campaigns that get this idea out there and help people understand what it is that's going on. Now, let's see if I can do this. This will be an interesting thing. Here we go. Here's an example of a youth campaign that we're working on around the one choice. We also use the word I am one. So the person can say, I am one, and one choice is my campaign. And you'll hear both of those here. Hold on here. I hope you'll hear it anyhow. Let's see here.
Many young people feel like the only one when they make the healthy decision not to use alcohol, nicotine, and other drugs. The truth is, most RI youth do not use substances, and that number is growing every day.
I am one. I make one choice because I want to be healthy and happy, and I want people to know that it's okay to not want to drink or do drugs because everyone else is doing it. I want people to know that you don't have to feel pressured into doing something you don't want to do just because everyone else is doing it.
I am one. I choose to be drug-free because I am a student and I'm an athlete and I want to keep my body healthy for as long as possible.
I am one. I don't do drugs because I want to feel like I'm in control and I want to be able to make my own choices.
I am one, and I make the choice to be drug-free because I'm an athlete and I want to keep my body healthy.
I am one. I make one choice to avoid drugs and alcohol to pursue a childhood dream. Growing up in a basketball family, I had a lot of role models that were great basketball players and hardworking people. From then on, I decided that I wanted to play Division I basketball. My priority was to become a hardworking, successful Division I athlete, and I avoid drugs and alcohol to maximize my athletic ability and to optimize all the opportunities that I have.
I am one. I make one choice to be drug-free because I don't desire to put them in my body.
I am one. I make one choice to be drug-free because I want to be a role model to my younger sister and to my teammates.
I am one. I make one choice because I don't want to be controlled by anything.
I am one, and I make one choice to be drug-free because I have a goal to pursue neuroscience or neurosurgery, and that's something that really interests me. And making sure that I'm staying off of drugs is important in making sound decisions for myself and in the future for others, hopefully maybe patients. So it's important that I keep my mind where it needs to be in order to reach my goals.
I know in making the choice to be drug-free, you can feel alone.
But we want you to know that you are not alone.
Because I am one.
And 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 I am one.
Let's make one choice together.
Okay, how do I get back to my slides here? Are you there? Oh, I'm going to start again. I don't want to start it again. Oh, no, I don't want that.
Dave,
Again, am I still here?
you are, sir.
Okay. Well, okay, I just want to say, because we're running out of time, to thank everybody. And to especially thank Amy and Carlton for this for putting this together, and how honored I am to be here. And that's it. Thank you very much. Proud to be with you.
Dr. DuPont, we are excited and honored to have you. We know your time is extraordinarily short. So with that in mind, I know that there was a question there.
Well, I can do one question. What's the one question?
So the question really is around the fact that some of our policymakers seem to have a blind eye to what you've presented and this problem. What would be some suggestions in getting this one choice campaign into our communities? And so it's kind of a broad question, but there you have it.
It's an uphill struggle because they've normalized youth drug use. And that is pathological. That is a big problem to do that. And I think that one of the things that we've done with this data is to show, first of all of it's related. I mean, that is a very big deal to get to that, because people go at this piecemeal, one thing and another. They'll talk about the opioids. There is no opioid addict who's not using 20 other drugs. It doesn't happen. And so the idea that it's all one, that's really important. And then the other thing is that there's a big change going on already. You don't have to make it up. It's going on by youth. And what we need to do is identify that, get parents to think about it, get pediatricians. We've been working with the Pediatric Association for a decade to get them around it. It's very hard for pediatricians to say to kids, don't use it all. But they're getting there. And they can do it by remembering it's a health standard. This is not prohibition. Yeah. We're not locking anybody up. We're just establishing a health goal and making it clear what it is. It's not responsible use by youth. That is irresponsible to have youth make a decision like that, because they'll like it because of the brain effect. This is a stupid experiment. And you're going to lose a lot of youth with that experiment. And I think just again, being just very, very clear with them, everybody about it. It's shocking to people to think about it. They sort of given up on the idea, but the kids have had the lead in this, and it wasn't recognized until now, but it's been going on for 4 decades.
It is one of the strengths of the one choice message is that it is extraordinarily clear and clarifying, and has actually revolutionized the way I look at and approach my prevention work. And so I thank you for that. I would offer to the questioner that it is indeed having an impact with policymakers as well, because in fact, the NISTA survey that has recently come out and others have begun to capture data in the same way that Dr. DuPont has now presented it. And that was, I think, a direct relationship or direct result of your impact and the influence that you've been able to have and IBH has been able to have. So again, Dr. DuPont, thank you so very, very much. I'm going to offer my gratitude and send it over to my partner in this endeavor, Amy. Go ahead, Amy. Thanks so much and bring us home.
Thank you, Dr. DuPont. As always, great information and wonderful delivery. And we're so thankful and grateful that you were able to be here with us today. I think we have a lot of homework. So just some things that I wrote down really quickly were make sure that you guys all look up the organizations, and I'll try to send an email to everybody that kind of gives you the websites, the organizations that were on here today, and follow them on social media so that you can share all the wonderful things that they're doing. Join ISSUP, promote the Listen First campaign and the One Choice campaign, and check out the resources on the PTTC websites. And also we'll be on the lookout for that new virtual launch of the ITTCs, and I'm hopefully not messing all these abbreviations up, but I'll make sure it's clear in the emails. So on behalf of Drug Free America Foundation, the World Federation Against Drugs, and my always great co-host, Carlton, thank you for taking the time to be here with us today. And more importantly, thank you for the work that you guys are all doing in your communities around the globe. Preventing drug abuse, curbing addiction, and increasing the number of individuals in recovery, there's nothing more important than that work. And you're doing that work every day and you're saving lives. Please feel free to reach out to us. You have our emails. If you have any questions later on, we're happy to help answer them and forward them to the appropriate person. And for those of you who are ending your day, thank you for spending the end of it with us. And for those of you who are just about at lunchtime, we hope you had a great morning with us. Thank you so much, everybody, and have a great rest of the week.
Take care. Goodbye, everybody.
Bye.
Thank you, Dave. Dave Clausen. Thank you, our amazing behind the scenes wizard, Mr. Wizard. Thank you, sir. Thank you, Chuck. Thank you, Kristina.